Good morning, everyone. Thank you all so much for being here. My name is Azva. I'm part of the CoRe planning committee for this event. So just some housekeeping before we get started. I know things have been a bit delayed because of weather, but before we get started, just make sure that everyone is sitting. We ask everyone comes and sits up as close as possible to the stage, just so it's not so far behind. We can see everyone. All presenters were assigned their positions. So if you don't know where you're supposed to be, just ask. Bathrooms and restrooms are located in the back of the classroom. And without further ado, we'll get started. So to begin, I'd like to introduce Senior Associate Dean of External Affairs, Dr. Rhonda McIntyre.
Thank you, Aspa. Good morning, everyone. It is my pleasure to be here this morning, and it's even more meaningful that you all braved or at least we did not have significant adverse weather from Brett, and you were able to be here this morning. So there are a lot of folks who are behind the planning in ensuring you were here this morning on time. So thank you. I think we have all presenters here, maybe save one this morning. Let me welcome you all to the inaugural CoRe Symposium. Last fall, RosMed launched the Community Medicine Global Health Program. And this program formed part of the work we do in the Barbadian community as part of the work in external affairs. We leverage the intersection of our internal community as well as the external community to create a learning environment for students and our faculty. In so doing, what we did was we brought our classroom to the community. Well, you might be thinking, why was this so important? Part of the vision in so doing, creating this program and creating the environment, was to foster intellectual challenge and a spirit of inquiry within our community to further scholarship. An opportunity for students to share their work was essential for growth, and a student research symposium was conceptualized. The CoRe Symposium is a student-focused event and seeks to create community connections through research. Students, you have seen firsthand how what you learn in the classroom translates to the community and is aligned with the experiences that you're having through the community clinical experiences. As you begin to appreciate the relevance of community-based research, we will continue to support you and support your development as scholars and give you opportunities to collaborate and communicate your ideas and your work. Our dedicated and talented faculty members, some of which are here today, some of whom are here today, who continue to enrich the community academically, have been integral in advising and guiding you to where you need to go intellectually. Today, I welcome you all as we witness our participants, presenters, collaborators contribute to furthering the intellectual mission of Ross University School of Medicine. At this time, I'd like to welcome Dr. Inequities. Dr. Athley is the Director of Student Research and Course Director of Community Medicine Global Health. Dr. Athley.
Good morning. I'm so excited to see everyone here today to lift our students and colleagues' research minds up. In this, our first CoRe Symposium, Community Connections Through Research. And our mission is to create these research-focused connections between the Ross community and the communities in which we reside, but also within the Ross community, so between departments, between colleagues and faculty and students. I will be your moderator today. We have 3 types of presentations today toward this goal, including 1 networking session between faculty and students. We have 8 faculty members which willingly offered to kind of share what their thoughts are and what their minds of inquiry are, and students will be able to have conversations with them today. Our posters aren't yet up because of delays of everything, but they will be up throughout this session, and then you'll be able to see them. But in this classroom, we have 2 sessions. The first one, students get to present their research ideas, things that are burning their interests. And the hope is that they can get some feedback on how to take that forward, but also to connect with faculty that may be interested in that work. Each student has 3 minutes to present, so it's a very short, punchy, exciting presentation, and then we'll have like 2 minutes for questions for each student. In the next session, finalized works or works in progress will be presented by students and colleagues, and we will ask questions at the end of all presenters in that session. We have a variety of semesters represented today in our presenters, a variety of departments as well, clinical, external affairs, medical foundations, and we invite you to connect with our presenters and ask them questions and generate that mind of inquiry. A warm welcome also to our esteemed judges. So we have Dr. Jennifer Connolly at the front here. We have Dr. Stephanie Date and Dr. Enrique Fernandez, who will be joining us online as a part of our judges. Their job is very important, so I really, really want to thank them for taking the time to do that. A bit of housekeeping. I know I promised you breakfast, but breakfast is delayed. It'll come around 10:30. So once that happens, I probably will just let you guys know, and we will decide what we want to do at that point, okay? So very sorry that if you're hungry and you came wanting to eat. So without further ado, we'll get started. Asva will moderate our first session. She's been so great in this entire process, and she will moderate our first session for us, where students are sharing their research ideas. I see the first slides are up already. Asva, thank you.
All right, so for our first set of presentations, these are students, right? We asked students to submit ideas for research ideas and research proposals. So without further delay, I'll just go ahead and call up the first presenter, Hardin Johnson.
Good morning, everybody. It's good to see all of y'all. My name is Hardin Johnson, and I, with Patrick O'Dowd and Eric McTran, we'll be working with Dr. Iliabova, and the title of our project is Preclinical Medical Student Willingness to Engage in Community-Based Medical Emergencies. And first off, I'd like to define, when I say community-based, I'm talking about in public, so gas stations, train stations, just outside of a healthcare facility. Today I have 3 minutes to talk, and in those 3 minutes, 97 people will go into cardiac arrest and pass away. 69 people will have a stroke and pass away, and 7 people will unfortunately pass away in some sort of traffic accident, whether it be as a pedestrian or operator of a vehicle. And this is where we believe that our research project will step in, because unfortunately physicians are not always going to be there when emergencies come. And so what we want to do is we want to be able to step in and identify, among us Ross students, what variables and what works for and what works against, helping us be motivated or having a little bit of resentment for stepping into and helping in emergency situations outside of healthcare facilities. So our goal is to identify these variables, and we're going to do this through 2 different ways. Our first question is to see how curriculum plays effect into whether or not we're willing or whether or not we're resenting to help. And the second, we want to talk about the demographics and see whether things such as gender, previous background, academic performance play a role in that. And as you can see, our methods, we're going to send out an anonymous survey consisting of questions as those listed above. And the overall outcome and what we hope is that we can improve the overall medication, not only here at Ross, but with everybody, and identify what barriers work for and work against us students helping out in emergency situations without physicians being present. So with that being said, I think we're ready to do our Q&As. So thank you.
So for Q&A, you all should have received booklets along with a notepad in there. So we ask that everyone, if you have any notes for any presenters, please go ahead and jot them down on your notepad. And towards the very end of the session, we'll be able to have questions for all students presenting. So thank you so much, team, Hardin, and everyone else. So up next, we have Cheryl Balikulam. I'm sorry if I missed that. Sorry.
Good morning, all. My name is Cheryl Voliklum, and I'm a third semester student. So today I'm going to be presenting how do healthcare providers' perceptions of the risk of contracting HIV from occupational exposure impede healthcare quality in Barbados. So a healthcare provider's behavior is largely influenced on their attitude and knowledge. In a study done by McLean in 2016, it was identified that physicians often used double gloves while treating HIV-positive patients. Similarly, in a study done by OJ et al. In 2014, it was noticed that among 150 first-year medical students in Barbados, their attitude was measured toward HIV patients, and it was noted that only 22.7% were willing to work with HIV-positive patients. This hesitancy was further described by a study done by Philip et al. In 2016, which showed that students were often stricken with an overwhelming reaction to the encounter with HIV-positive patients. So in this proposed study, I want to focus on the implications of practices that were internalized, which include religion and sociocultural norms. So what is the influence that religion has on the perception of HIV? According to Kang Dufar et al. 2013, FBOs utilize the doctrine of abstinence till marriage. Therefore, if a person contracts HIV, it is considered that they were engaging in sexual activities that were considered to be sinful. Furthermore, Coleman et al. In 2016 identified that persons who were closely affiliated with their religion had a stronger negative connotation and an unwillingness to interact with HIV-positive persons. Similarly, what is the influence that sociocultural norms have on the perception of HIV? Rambaran and Grenfell in 2016 explored how healthcare providers can be perceived as insensitive or having a negative attitude toward HIV-positive patients. This study found 3 key findings: incomplete sexual histories, varied understanding of sexual and gender identity, and an invisibility of LGBTQ+ patients and their specific health needs. Therefore, a self-administered survey measuring religion and sociocultural norms on the public sector of Barbados will shed light on the discrimination of HIV. The proposed methodology would consist of 5 categories as shown on the slide. Knowledge of HIV would be measured to rule out any error in the understanding of HIV and to show that there are external, more complex practices such as religion and sociocultural norms. I hypothesize a strong association between the practices of healthcare providers and their behavior. Therefore, with the development of the Barbados National HIV Strategic Vision for Zero Discrimination, implementing a mandated CME course would be beneficial. To leave you with the thought, AIDS does not spread by a virus, but by ignorance and lack of awareness. Thank you.
Okay, so thank you so much, Cheryl. So before we move on, actually change of plans. We're going to be taking questions right now. So could I have the previous 2 presenters come up, please? And if anyone has any questions, are we getting a mic to pass around so we can get questions? Yes. Yeah. We'll just get them come up. Do we have a mic? Can we get a mic? Okay.
Oh, okay. So, first of all, I'm really thrilled to see the presentations and the thoughtfulness that went into them. For the first presentation, I'm wondering if you're going to be measuring self-efficacy as a variable, as a determinant of whether or not students are willing to help in those emergencies.
So the first question was for the first presentation, and the question was whether it will be efficacy. Sorry.
The student's self-efficacy as a determinant of whether or not they will step in.
Okay, how they will be measured. So the question is how you will be able to measure student efficacy when it comes to the measure, right? Is that what your question was?
Yes, that's our goal actually, is to do it that. So a lot of the variables are kind of almost playing into, we're measuring the self-efficacy itself rather than that being a variable. So our variables are almost playing into the self-efficacy to find out how willing we would be to help.
We have an appendix to show our type of questionnaires.
Good morning, everyone. So well done, both presenters. You guys were awesome. So my first question is for Hardin's group. I think this is a fantastic study, definitely needed. I was looking through the questions you were considering asking, and I was just wondering, have you also considered asking about students' previous experiences? So for example, have they ever been in a situation before, or have they lost a loved one to any of those things that you mentioned?
Yeah, can we have whoever's controlling the PowerPoint to pull up our deck? We do have an appendix section where we highlight our three main categories: contingent on demographics, situational base, and some variables that we think can compound on some of our core statistical confidence variables in which education plays a big role. But things like religion, their past experience in being exposed to these scenarios, whether someone's having an obstruction, an airway obstruction, or someone that's going through a stroke. So all that's going to be baked in. We're going to bifurcate it primarily first through educational competency, and that's self-assessed on a student basis, as well as some more binary, such as what's their GPA level, what semester are they in, and such. So we can make this available to anybody who's interested, but we do have this for you guys to view.
Thank you.
Anyone else? Any more questions?
So just for 1B, can you just outline what type of study it's going to be? It's you, 1B.
So the proposed study would be a survey. So the demographics section would have questions using outlined ranges, such as if it asks for age, it would be 15 to 20, 20 to 25. Then for the knowledge of HIV questions, since it is pertinent that a physician has the knowledge of how HIV works, those questions will be based on true or false questions. And then the sociocultural norms, religion, and attitudes will be based on a Likert scale, which ranges from 1 to 5, and that would assess how they feel about the statements that are presented.
So to categorize your study, would it be a case study, a cohort study, a cross-sectional study?
Cross-sectional study.
Dr. Adderley is smiling. No further questions.
Did Dr. Connolly have a question?
Thank you both. I have a quick question for Cheryl. Just in relation to your talk, you give a really astounding statistic that about 20% of students in Barbados would have an issue treating patients with HIV. I wonder, just from your experiences, or maybe from your class members, your peers, how do you feel our curriculum is doing with regards reducing that stigma with our students here?
I do feel that the courses so I am a third semester student, as I mentioned previously. I feel as though sorry, I'm blanking on which part, but the presentations given by like the physical wellness and like competency era, like, oh my goodness. They give a well-defined reason of like the clinical practices show us that it's important to ask questions and like never assume. That's one of the statements that I've had in my head at all times. Never assume. I think that statement has been said to us multiple times. So that's why it's pertinent just to always ask questions and to never judge. So we have received curriculum in relation to how to treat patients who may be different than you are. We know how to encounter them and hopefully have a better perception. So the study was done in 2014. So it has been a while since then, and this was in first-year medical students. So I'm hoping with the more education we receive, that the more we'll be able to reduce this stigma.
Any more questions? All right, thank you both groups for presenting. All right, so we'll move on to our next presenter, Lawrence Wong.
Good morning. I am Lawrence Wong, and I am a first semester student here at Ross University. My topic is on the significance of RAS-like mutations on treatment of thyroid neoplasms. So when is cancer not a cancer? Up until a few years ago, the image on the bottom right would be diagnosed as follicular variant of papillary thyroid carcinoma. Except when clinicians and researchers look back on data, it didn't really behave like cancer. It was indolent. It didn't invade through the thyroid capsule. And so in an effort to spare patients unneeded overtreatment, a panel of experts proposed reclassifying this tumor as a neoplasm. And as a side note, if you look at the fourth author there, Dr. Baloche, he's a pathologist at the Hospital of University of Pennsylvania, where I worked as a cytotechnologist, and together we are collaborating on this project. Next slide. So when we look at the genetic profile of thyroid cancers, we can see roughly two distinct populations. So the more indolent tumors have a distinct genetic profile. And if you look at the profile that I circled, this is non-invasive follicular thyroid neoplasm with papillary-like nuclear features, NIFTP. So this is what the variant of papillary thyroid carcinoma was reclassified into. And we can see that this tumor has a genetic profile that we call RAS-like mutations. So it includes RAS mutations and also a couple of other mutations that are more indolent in nature. This is opposed to BRAF-like mutations, which are more infiltrative. Next slide. So this is a general overview of what happens when a physician detects a thyroid nodule in a patient and orders a biopsy to determine whether or not it may be cancer. So when we get the sample in the laboratory, a pathologist would examine the specimen and make a diagnosis based on a sliding scale. In the United States, we use the system called the Bethesda system, and it ranges from Bethesda 1 all the way to 6, so 1 being benign, 6 being malignant. However, in the middle, there's this gray zone, an indeterminate diagnosis, where we as in the pathology lab cannot determine if it's truly benign or if it's truly malignant. So malignant cases or even Bethesda 5 suspicious cases can go directly to surgery because we are fairly confident that it is cancer. However, indeterminate diagnoses, oftentimes we just don't know. So recently, a genetic test has been developed, which is able to look for these RAS-like mutations. And together with the pathology report, it is able to give us a better idea of whether or not surgery is needed. So my research, however, if you look at the research literature, the malignancy rate for this group ranges all the way from 10 to 80. And that is because the research is lagging since the name change just occurred. And so my research project will look at our case files in order to determine whether or not truly these patients can be treated conservatively or more aggressively. Thank you. Anyone have any questions? Yes.
Well, that's intense. that's great, though. So if you had to summarize what your aim is, can you tell us your aim, and do you have a hypothesis?
Yeah, so the aim of the study truly is to be able to see if patients with this NIFT-TP diagnosis can be treated less aggressively, and so not needing surgery, just not needing like a total thyroidectomy, but just the lobectomy will suffice. So the hypothesis of the study is that patients with diagnosed as NIFT-TP with RAS-like mutations can undergo lobectomy alone, and further management can be based off of like benign modalities such as observation and surveillance.
Great. And in this type of study, do you think you need a control group? And if not, why?
We've debated this, but in the end, since we are dealing with like true clinical patients, we can't like designate a control group saying, yes, we know you have NIFT-TP and we know you have this mutation, but we're going to hold off cancer because in the clinic, we just cannot have the risk for the patient developing cancer at that point. Thank you.
Thank you, Lawrence. And our next presenter, Alexander Priesig.
Hello, good morning. My name is Alexander Priesig. I'm a semester 3 student here at Ross, and I'm presenting today on a topic that I'm a bit personally invested in because I was diagnosed with hereditary hemochromatosis when I was 18 years old. And I know that there are many patients who are not as fortunate as I was to be diagnosed so early in their disease progression. So I would relish the opportunity to play any role I can in improving their own clinical outcomes. And so hereditary hemochromatosis refers to a group of inherited diseases in which iron metabolism is perturbed. Because the regular pathway of the iron regulatory hormone hepcidin is impaired, you get an increase in dietary iron absorption. And over the years, that excess iron that is absorbed gets deposited in various tissues across the body, including the heart. And after several decades of being asymptomatic, patients eventually show up, present symptomatically with a whole variety of things, including damage to the heart, which consists of a dilated cardiomyopathy, which could progress to heart failure. The other issue in this cohort is because these patients are asymptomatic potentially for so long, by the time that they present with symptoms in their 40s and 50s, your medical interventions are not always as successful as they could be. Now, the standard treatment of patients with hemochromatosis is either phlebotomy or iron chelation, depending on the individual factors of the patient. My proposal is to include erythrocytophoresis as part of the routine standard of care for these patients presenting with these issues. Now, erythrocytophoresis is conducted by the machine that you see on the screen, and it's not that scary. I've done it before when I've donated blood. It's actually kind of cool. What they do is when they take the blood from you, the machine extracts the red blood cells from the blood sample, and all the remaining elements of the blood are reinfused back into the patient. Now, this is also already something that's in practice with other diseases routinely, such as thalassemias and malaria, and the studies that I have read in the literature have already demonstrated therapeutic benefits, including more rapidly declined iron levels in these patients, as indicated by ferritin levels and transferrin levels, but also some studies in the literature have also reported a reversal of cardiac tissue deterioration. The method that I would go about this is a meta-analysis of the current literature. And my hope would be to publish some kind of result that influences the current state of management such that erythrocytophoresis becomes included in the standard of care for these patients. And I know that part of the issue that I will have to overcome, that I do pose to the audience, theoretically, is number one, how do I sufficiently justify that erythrocytophoresis should be included in the standard of care, routine standard of care for this cohort of patients? And number two, how do I adequately prove to the hospitals and facilities taking care of these patients that any cost incurred to them by the maintenance and care of these machines is outweighed by the benefits to these patients? Thank you.
Any questions? And I would like to open up the platform to students as well. So, but I see one.
Thank you so much. I was wondering how often this erythrophoresis can be performed to those patients, and what are chances to get anemia after this intervention? Thank you.
I'm sorry, doctor, what was the first part of the question?
How often?
How often?
Yes, and second, what chances to get anemia?
So from what I've read in the literature, because the process does lead to an increased quantity of red blood cells being extracted from the patient, I do know that the time frame does have to be a little bit longer between each bout of blood removal. I don't have an exact number from the literature. Speaking from my own experience, when I have done such a procedure, when I have donated blood, I know that they ask that a full 8 weeks goes by between different erythrocytophoresis encounters. And in regards to the anemia, I am aware that some patients may be at risk of anemia due to individual, complications, the exact nature of which hereditary hemochromatosis form that they have. From what I understand, the risk of anemia is not very high, because by the time that they are symptomatic, the levels of iron that they do present with are such that they would not be anemic by the time their treatment schedule is complete.
Thank you.
Do you have a sense on a preliminary basis of how studies that have tested the potential efficacy or effectiveness of erythrocytophoresis in this condition? Since you're going to be doing a meta-analysis, I'm just wondering how much literature there is that you can look at in your study.
I do admit that is one of the downsides of the study. Of the potential study, from what I've read in the literature, a lot of the existing knowledge base pertains to individual patients that have been written up as a case study, or anything that has been a bit larger pertains to a very small individual group of patients, only like a handful, I think, if I could be wrong, but from what I remember reading, between like 10 and 20 patients are the largest group that I remember seeing. So while I have seen individual studies that have suggested that this is a beneficial therapeutic intervention, I have not seen anything large enough that would dramatically warrant the altering of the standard of care.
Yeah, so I have just a quick comment. So it may be that there isn't enough data out there to accrue to a true meta-analysis, but nonetheless, I just encourage you to pull what's currently available. You may be able to do a hypothesis generation, so to speak, to support that. Maybe the larger studies should be done to answer your question.
I appreciate that. Thank you.
Any other questions? Thank you. One more question?
I thought I saw a hand raised.
I just wanted to find out if you're aware of like the cost that it would cost for a patient versus like the hospital to do this therapy.
Honestly, no, I'm not entirely sure of any costs right now. My aim was to seek whether or not this type of intervention is even justified clinically before I investigate the cost of the patient versus the cost of the facility. Thank you.
Thank you, Alexander.
Thank you.
So without further ado, our next presenter, Shadan Al-Jada.
Good morning, everyone. My name is Shadan Al-Jada, and I'm going to be presenting early treatment of amyotrophic lateral sclerosis. So, distinguished guests and esteemed colleagues, it is with great pleasure that I stand before you today at this esteemed symposium. The gathering of brilliant minds, passionate individuals, and experts in their field is a testament to the power of knowledge and the pursuit of truth. As we navigate through a rapidly evolving world, the importance of collaborative efforts becomes increasingly apparent. Today, I would like to address a topic that lies very dear to me: amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. Now, for those of you who do not know what the disease is, it's a severe neurodegenerative disorder that affects motor neurons, more specifically voluntary muscle movement. The disease is characterized by slow progressive degeneration of these neurons, which eventually leads to the wasting of the muscle to the point of no voluntary movement. I have had the misfortune of seeing a loved one go through this disease, and let me tell you, it's not pretty. First, they start to notice aches and pains in their body. They start to feel weaker, unable to do normal day-to-day activities. Eventually, they can't walk anymore, lose the use of their hands, they can't talk, and eventually leads to death. So what is the issue? There is currently no known cure, and once the damage and degeneration begins, there is nothing to reverse the damage. The mechanism of action and cause of ALS is poorly understood and has contributed to a multitude of factors, including but not limited to superoxide dismutase gene mutation, SOD1, muscle denervation atrophy, Wallerian degeneration of axons, and much more. I saw a loved one go through 20+ doctors all over the country, and they all sent her away with the same message: we don't know what's causing your issues, we can't help you. She experienced years on end searching for a solution, until one day, 5 years later, she found a doctor that officially diagnosed her with ALS. Currently, there are 4 FDA-approved drugs to treat ALS symptoms, all of which aim to prevent and decrease severity of symptoms once they begin. However, there is no current medication being administered prior to the start of symptoms. And by then, it's only a waiting game of time. The goal of this research is to investigate if we treat individuals who have a confirmed SOD1 gene mutation prior to symptoms manifesting, will this slow down disease progression and in conjunction provide a better quality of life? To achieve this goal, this research aims to answer the following question: will starting the FDA-approved medication Reliviro early, before symptoms start, in middle-aged adults ages 40 to 70 with a confirmed SOD1 gene mutation delay the onset of symptoms and in conjunction slow down motor neuron degeneration? The challenges that we face as physicians are multifaceted and complex. Being that medication is usually administered when symptoms appear, this poses a great challenge. And then my question to the audience is, due to the fact that most medication is administered after symptoms, do you believe that this alternative approach will in fact prove beneficial, or will it be like a placebo effect? However, I know that in the face of medicine, sometimes we have to think outside the box in order to provide the necessary help. Within these challenges lies a seed of opportunity, hope. I stand before you today to help those like her not go through the same agony of searching for answers amongst a sea of unknown. By harnessing collective intellect, we can unearth innovative solutions that will shape a better tomorrow. Thank you.
Any questions?
Thank you so much, and thanks for sharing that. What kind of drug is Reliviro?
So it's a combination of drugs that it's used to block like cell nerve death by causing, like it basically stops the denervation of neurons. So right now it is currently in FDA phase 2 trials, currently working on phase 3. Was approved for phase 3 since 2022. So it's still a fairly new drug, and it's still barely new on the market. A lot of people haven't even tried it yet. So that's why I wanted to do the research on using this new drug in conjunction and seeing if doing it prior to symptoms manifesting, being that it does like block nerve cell death, would that slow down the disease at all?
Great. And whenever we do a study, it's always important to think about the risks to the patients, especially with randomized control trials. When you do your informed consent forms, what risk are you going to have to outline?
That's a good question. I think obviously with every risk, there is the risk of actually causing further harm than good. It could actually speed up the progress of the disease. Maybe the symptoms will start prior, so that will be something that will be noted. Also could cause premature death in these patients. Also with the fact that the SOD1 gene mutation is only found in 20% of the population, we don't know how much that this would actually, we would be limited to the population that we would be working with. And it's more consistent with familial ALS, not sporadic ALS, which is found in even less of the percentage of the population, which is like 5 to 10%. So there is risks associated with doing something that's completely non-controversial or non-common. But yeah.
I think that was the same question. So you just mentioned about the percentage of people with this disease being small. So how is that going to impact your study? I'm looking for 2 words in particular.
Can you repeat?
Because when you plan a study, you say, ideally, I want to capture this amount of people. So what am I trying to get at? What is your ideal sample size?
Well, 10% of ALS cases, which is 300,000 cases. So.
Okay, so when you do your study, you're trying to capture how many people in your study? That many?
Well, not necessarily, because we're looking for also patients who do not have like disease showing symptoms yet. So it'll be new patients, people who may be hereditary, who already know that someone is already affected in the family, and they did gene testing and found that they do have this mutation, and they're in their 20s or 30s and haven't reached the onset of time. So maybe 100 people?
Yeah, so it's always good when you looking over at Dr. Adderley, she might help you calculate sample size, but that's good. It's always good to think, how can I increase my sample size as well? Because especially with trials, you're always going to get instances where you just say, shoot, I want 10 people, and you're only getting 2. You have to think, how can I expand my sample size? But good luck.
Thank you.
Well done.
All right, thank you, Shadon. Our next presenter is Juliet Jordan-Joseph and Rainis Eddy.
Good morning, everybody. My name is Julia Jordan Joseph, and I'm a 5th semester medical student.
And my name is Rainice Edie. I'm a Forex student.
Okay, and we're here to present on our research proposal in which we will be evaluating uncontrolled type 2 diabetes in Barbados. The prevalence of diabetes in Barbados is 18.7%, which is the highest among North American and Caribbean countries. In addition, Barbados is the amputation capital of the world.
Okay, so the purpose for our study is to understand and find the cultural and socioeconomic factors that is leading to the uncontrolled diabetes in Barbados.
Identification of the social and cultural factors that lead to uncontrolled diabetes is the problem that we are trying to solve.
Okay, so the gaps that we're trying to fill in is, like we said earlier, is understanding the social detriments of the reason why diabetes is uncontrolled in Barbados, such as finance and transportation, as well as cultural aspects, noting that in previous years, Barbados' diet was more homegrown based versus now it's more fast food based. So we want to know if that has a role in it. And then previous research only focused on the provider's perspective. We want to focus more so on the patient perspective.
There are many benefits that can be derived by closing the gaps. First, we're hoping to tailor solutions and resources to help them manage their diabetes. In addition, we'd like to reduce healthcare expenditure. It was noted that in 2021, the healthcare spending on diabetes in Barbados amounted to $43 million. And this figure is expected to increase to $43.6 million by 2030. We're also hoping to improve diabetes outcomes. Some of the things we're hoping to reduce are the end-stage renal disease, cardiovascular disease, amputation, diabetic retinopathy, and neuropathy.
So understanding that diabetes is a huge problem here in Barbados, we would like to ask the audience, where would be the best place to recruit participants for this study to maximize our research?
Thank you.
Thank you. I just was curious, what is wrong in Barbados diet that leads to diabetes?
What's wrong with the diet in Barbados? I feel like you're trying to trip me up. So I was reading a research article that was basically saying back then they had more, like the women were housewives, so they cooked more. Everything was, homegrown, more gardening. But now due to economics, most people rely on two incomes to survive here. So it transitioned from homegrown, grown in a garden, to fast food restaurants like Chefette's, for example, or, KFC. So that has a lot to do with it. A lot of people is transitioning from their cultural diets to more westernized diets.
In addition, with the huge influx of Americans to the island because of the medical schools and other things, we have become more Americanized here in Barbados. And so people have become more sedentary, and also they are consuming more carbs and more saturated fats. And so we wanted to look at the social and cultural determinants on the patient level, because we hear from the providers all the time in the literature, but we wanted to see on a day-to-day basis what is happening with the patient. What are the struggles? Is transportation an issue for you? Are you not able to get time off work? Are you not able to go to the gym? Or is there a park near your house you can walk to? Do you have anybody to support you at home? All of these are the factors we're hoping to evaluate to see why Barbados, which is so highly educated, a place where education is rampant, why it is the highest among North American and Caribbean countries. So we definitely see that this is research that we are hoping to conduct this year to see if we can make a difference.
I would also like to add that if you even go into Massey or even Popular, I believe that's the name, the cost for healthy food is very expensive. I'm not sure what the minimum wage is here in Barbados, but I know just me basically living on a student loan is very hard to buy healthy foods at the grocery store. So.
So you asked a question about where you can recruit.
Yeah.
Hi. Yeah, so you asked a question about where you can recruit participants. So my suggestion might be to start at the Barbados Diabetes Foundation. Most of the public sector patients, if they are uncontrolled, they get referred there for a 6-month program. And I know they are keen on doing research in their center. So that might be a suggestion to start.
Can I? Oh, I think Dr. McIntyre has a question. Can I just play off of that very quickly? Polyclinics are also a good place, and there's also an endocrine clinic at QEH. But I want to ask a question, because if you were to only target participants in the polyclinic, so public healthcare, what biases might enter into your study?
Selection bias.
Excellent. Okay, so what do you have to make sure you do?
Blinding.
Okay, so you want to recruit patients from the polyclinics and also from
Maybe the place she was talking about.
private facilities.
Yeah.
Excellent. Sorry, Dr. McIntyre.
Well, it all comes together. I was simply going to say, do you seriously want us to answer that question? Because we have a good suggestion for you. And I would say the Barbados Diabetes and Hypertension Association, who we have strong ties with and we're already doing work with, they're not the patients who are going to the polyclinics for checkups, etc., or the foundation, but they're the patients. They have a database of basically most of the diabetics, I would say, in Barbados. So there's a rich base of patients that you could access through an organization that we already currently work with.
Thank you.
Excellent.
Thank you.
Just a quick one. Given the prevalence of diabetes in Barbados, how big of a factor do you think genetics has to do with it?
Well, based on what Dr. Lawson told us in his lectures, I think genetics plays an integral part in diabetes, especially among the African American population. Well, Blacks and African Americans and Caribbean. So I do feel that there is a genetic component. However, it has been if you want to accelerated because of the dietary changes and lifestyle changes that are happening at the moment.
To make a statement about the amputation capital of the world. That's per capita. So people like to say that we have all these amputations, but surgeons get very upset when they hear that, because what ends up happening is a vicious cycle. And the more we put that message out there, the more Barbadians are scared to come to the hospital because they think that they're going to get an amputation. So just be mindful. It's not your fault. That is a very big statement that people make all the time, but it's just to be mindful that the more we say that, the more people think, I come to the hospital, I get an amputation, but it is per capita. And we need to break that cycle. So I'm excited for you guys to do that.
Thank you so much.
Thank you. And one more question. Why did you decide to evaluate uncontrolled type 2 diabetes versus presence of type 2 diabetes in individuals, let's say like regular?
Well, if it's controlled, then the disease is not going to progress as much. But the uncontrolled part is the one that's leading to the problems that we have. Not that we don't want to get rid of diabetes on a whole, but we want to see what factors are leading to it, because it's not because they're not getting education or access to care. There's some other thing that is causing it to be uncontrolled. So we wanted to see what those factors are.
Also, if a patient disease is controlled, that either means their medication is working, they are actively taking their medication, maybe they're actively changing their diet. So when we wanted to do uncontrolled diabetes, I think that's why we wanted to focus more on the patient. Like, what's going on with the patient? Like, is it they're not understanding that you have to take your meds in order to get your diabetes controlled? Is it a finance problem? Like, they can't afford their meds, they can't afford a healthy diet, stuff like that. So I think that's why we're more so focused on the uncontrolled aspect, because that has like Juliet was saying, a greater chance of progressing to other metabolic syndromes.
And I wanted to add one more thing. There are tons of data on what foods that you can have to eat, with diabetes. However, the factor that's usually missing is the cultural component. What cultural foods in Barbados can you eat to help you manage your diabetes? And there's not a lot of literature out there on that. And so these are some of the questions we want to ask the patient. Do you know what cultural foods you can have to help you, manage your diabetes, so that we can tailor solutions such as like providing literature that will tell you which foods in Barbados will be good for you to eat if you have diabetes.
All right, thank you.
Just a quick one. In answer to your first question about who you can collaborate with, there's actually a diabetes foundation here in Barbados. It's been around for about 20 years. Maria owns the foundation. And they have their own building and all of that. So if we try to foster community partnerships, that might be an idea to start with, to get some collaboration on the island itself.
Thank you so much.
Thank you.
Thank you, Julia and Renis. Our next presenter is Julie John.
Good morning, everyone. My name is Julie John. I am a Forex student, and I'm here to talk to you today about nurturing cultural competency through ethnomedicine. So before we begin, I just want to know how many of you all have seen this or have heard of Ayurvedic medicine? Okay, I see a couple. So basically, this is, it's a procedure done to heal knee pain. It's called Janu Basti, and it's meant to reduce the swelling and pain and cleanse the knee of any toxins. So, okay, we can stop. And it's a form of alternative medicine that's used for pain. So let's go to the next slide. Okay, so what is ethnomedicine? So ethnomedical approaches, especially in the field of medical anthropology, it's a field that is used to make connections between culture-bound syndromes and perceptions of disease etiologies, as well as health-seeking behaviors that are quite different throughout the globe. Next slide. So this requires a collaborative effort, not just from the physicians. I believe social workers, nutritionists, nurses, occupational therapists, they must take into account the various theories of culture-bound syndromes, because as you can see, that the patient is not only influenced by a provider, they're also shaped by the family's decisions. Sometimes care is family-centered. So by combining complementary treatments with biomedical approaches, we can, I believe, integrative medicine is how we can hope to improve patient turnout and improve the quality of care as well. So as you can see here, for Parkinson's disease, there's an approach, there's a traditional medicine approach, which uses like the carbidopa and the levodopa, but there are like conventional medical approaches that you can used, such as like herbal meds and stuff like that. But, you know, the studies, there's like a lack of evidence-based approaches out there. So that's something that I wanted to pose as a question. Next slide. Okay, so some of the interventions that I've been thinking about, there's a lot, but I could only choose a couple, is to encourage physicians and healthcare professionals to analyze our own biases and beliefs that may interfere with approaching patients of different ethnicities and cultures. Hiring interpreters to cater to different minority cultures and languages in the US, and understanding why some may choose to take care of their health elsewhere. Mainly it's a cost issue because healthcare in the US is expensive. And then lastly, to start these evidence-based studies and involve pre-medical students, medical students, on non-invasive therapies such as Ayurvedic medicine and herbal medicine. So as you can, okay, that's fine. You can, okay. So this is from a Grey's Anatomy episode. I don't know if any of you all have seen this, but basically, Anna is an Asian American girl who's a part of the Hmong culture, and you know, she's in need of a surgery, but then her parents say that they need to have her soul's intact because they believe that there's a soul that's in pain or that's lost. So I'm just, oh, you can play the video. But basically, I'm not saying that we should shift to this. I'm just saying that we should be open-minded and have.
You're standing beside me in a $3,000 suit, so I also know that you respect the fact that I'm telling you Anna needs a surgery in the next 24 hours if she's going to continue to walk. She can't leave this hospital.
So at the end, I think they let her have the surgery, but before that, they allow her to have the ritual with the shaman. Yeah, that's just something that I wanted to show because they showed it to me in my medical anthropology class at UNC.
It's a guy with access to a helicopter.
So, that's fine. So I wanted to open this question to you all. So how can we make Western biomedicine more patient-centered and educate aspiring / current health professionals on evidence-based complementary and alternative medicine? So I would love if you guys have any ideas, or I do have a couple.
I have one. Do you think we do a good job with exposing our students to alternative medicine?
I feel like, so there was a lecture by Dr. Selfridge, actually, and she had like a bar graph. Oh, sorry. There was a lecture by Dr. Selfridge, and she had like a graph that showed how many patients choose yoga and meditation and stuff like that. But I feel like we need some sort of like a club or something like that to drive home this message, because I'm not like against biomedicine, Western biomedicine, but I feel like there are instances when we need medicine and instances when we don't, or we can usually what I do is I combine different approaches. Any other thoughts or?
Hello. So my parents are, by being of Indian heritage, my parents are huge in Ayurveda medicine, and my neighbors are not. So one of the biggest debates that they have at home all the time is, will you be doing a study where, so right there in that question, you say evidence-based complementary and alternative medicine. So will this alternative medicine go through stringent sort of regulations and be checked to see if it's actually efficacious? Or is it going to be word of mouth, as in, hey, I'm also taking some pills, but at the same time, I'm doing this whole new therapy. This therapy is helping me and it's not the pills.
Yeah,
How do you differentiate that?
That's what I was saying. I feel like I'm calling on evidence-based therapies to check and see if there are any, like for example, you can take flax seeds for diabetes. Actually, it's like it has a similar efficacy to metformin. Don't quote me on that though, because I read it somewhere and I don't know if it's like. That's personally what I'm taking. I'm not diabetic, but like I take it sometimes just because it's good for your health. I got kind of carried away. So basically, I feel like we would have to do like studies to see like if it causes adverse effects to the medication. I'm not really sure. Another thing that we can do is take a medical history and maybe add on to that, like, the observer feedback form, to add on and see, like, is there anything else that you believed works? And, yeah, we need to add on, I feel like, to the form.
Thank you.
Yeah, no problem. Yeah, this is something that I plan on working on when I'm in clinicals and stuff. So I just wanted to start off with this.
Hi, good morning.
Hi, good morning.
Excellent presentation. Congratulations. I actually think the question that was asked just before me raised a very interesting point. Have you considered starting with analyzing the knowledge and attitudes of healthcare professionals, medical students towards complementary therapy as a starting point of this?
Yeah, I believe like that is the number one thing that we have to do, analyze the biases and knowledge towards alternative medicine, because I feel like a lot of people don't know about this, and I feel like it starts in the medical schools. We need to educate students, have an integrative medicine topic or some sort of lecture on that. Yeah.
Do you think that medical schools should spearhead research on some of these alternative medicine so that we can have some clinical trials to show that they're effective? Because I think the problem is that many times people don't know whether or not to use a thing because there's no data that supports it in literature. So do you think that that's something that medical schools could do?
Yeah, I feel like part of that block, like if we do like an integrative medicine sort of block or something like that, we can ask students to do a research project or something like that, or we can involve like the Ministry of Health or someone higher up, because it does require a lot of money, right, to go in and
Hi. So this is more of like just a comment. I have a friend who's actually in naturopathic medical school, and that's also another field. It's medical school, just like what we're doing, but they also do more integrative approach. So they have like Oriental medicine. They learn about a lot of like herbs and different things like that. So maybe also partnering with somebody who's also in naturopathic medical school, even different herbalists and things like that could also be a good idea for you.
Yeah, I totally agree. I think, maybe like medical schools could have like a guest lecturer come in and talk about that, someone that's more knowledgeable. Yeah.
Hi, just a quick question. I agree with this, and I think this is totally good. I'm from the Bahamas, and we do bush tea. But my question, though, is
are you going to think about the physician, the MD, because when you have the alternative or the complementary medicine, does that somehow negate going to the physician? Or not negate, but I don't know, if there's some kind of bias that, oh, well, I can take this bush medicine and I don't need to go to the doctor, how is that going to play out in the long run, I guess, if that makes sense?
Yeah, I feel like I was saying earlier, I'm not against like drugs or anything like that. I feel like, you know, it's needed for some things, you know, like I don't know, like surgery and stuff like that. It's needed, but I don't know. I'm open to, like, you know, anything. Honestly, this is just I'm at an early stage in this, but I would love to like collaborate with people that are more knowledgeable on this topic. Yeah. Thank you.
I just wanted to play off of what Dr. Daisley said, because I think that was really important. And when you do research, the exciting thing is when you think of an idea of, I want to do this paper, and you find that it's been done in a different population, you can then kind of say, oh, copy, paste. The study design is there, everything is there. And in 2017, there was a paper done in Trinidad and Tobago, and they looked at the knowledge, attitudes, and practices of healthcare professionals and what they thought about complementary medicine. So I'll save the article and I'll send it to you. Okay, and I just think it's really good to go through, see what their limitations were, see what their study design was, and if it's novel to Barbados or your population, then you can do it. And there was an article in 2021 that was published in the Journal of Ethnopharmacology that looked at botanicals in Barbados as well. So I can send you that also if you want to look at it.
Perfect.
But good job.
Thank you so much.
Welcome.
Thank you all.
Thank you, Julie. Our last first set of presentations is presenter is going to be Melissa Livingston.
So good morning, everyone. My name is Melissa Livingston. I'm a semester 3 student here at Ross, and I will be presenting my research idea on how does iron supplementation affect the physical performance of iron-deficient female athletes. So a little bit of background. Iron is extremely important in female athletes due to the strain put on the muscles during training and competition. But more importantly, menstruating females, especially those who experience heavier bleeding, at an increased risk of iron deficiency and anemia, which can impair physical performance. So many factors increase the risk of iron deficiency, specifically diet and uterine fibroids. So just being here in Barbados, for example, the diet is mainly consists of high carbohydrate diet. And in a recent article put out by the Barbados government, it stated that Barbadians continue to eat meals prepared outside of the home, which are high in salt, refined sugars, cholesterol, trans fat, and saturated fats. And in addition, Barbados has a significant Afro-Caribbean population, and we know women of African descent are at a greater risk of developing fibroids even at a younger age. So fibroids can also increase bleeding, making it heavier, which can lead to anemia and iron deficiency. So again, my research question, how does iron supplementation affect the physical performance of iron deficient female athletes? So my population would be Barbadian female athletes ages 15 through 30 who are iron deficient and participate in endurance sports. My intervention would be iron supplementation. And my comparison group would be persons who eat an iron-rich diet. And my outcome I'm looking to hopefully be effective at improving physical performance. So one of the ideas that I came up with was a 6-month intervention. And I would partner with local physical therapy and sports medicine clinics on the island to identify female athletes. And I will conduct a sample size calculation to determine how many participants are needed for this study. We would draw our own labs to obtain baseline hemoglobin, ferritin, and hematocrit levels. And so performance tests, how we're going to test this, is like weekly walking and running or running treadmill tests to measure VO2 max. And hopefully, I'm looking for an outcome. So my outcome would be by further investigating iron deficiency in female athletes. Specifically, this can help create and improve the screening protocol. And this can help clarify like ideal iron requirements for the athletes and highlight just the effects that iron deficiency can have on performance. So some potential dilemmas and questions that I have. So the sample size not large enough, and one of the things that we thought of was expanding our criteria, expanding our inclusion criteria. So just including like all sports. Also, there's no restriction on a patient's diet, so iron intake outside of the intervention is not accounted for. So intake could be higher or lower. And one of the things that I had thought about was maybe having our participants keep a diary, a food diary. Sports-specific testing will reveal differences in performance between iron-deficient groups. And two big questions are, what are the best places to recruit? So I had thought about maybe using sports medicine clinics or physical therapy clinics, but also maybe just using actual medical clinics because patients could already be diagnosed with iron deficiency. And then also using persons diagnosed with iron deficiency versus us taking our own labs and diagnosing patients with iron deficiency. So those are my questions. Thank you.
Thank you, Melissa. I'm over here.
Sorry.
No, hi. Thank you for your presentation. I just wonder why you are suggesting iron supplementation ahead of maybe addressing dietary iron deficiencies in these individuals?
To be honest, no reason in particular. I just know like you could supplement with iron. I guess in my opinion, I don't know if this is like true, but I feel like maybe it's a little bit more easier for people to supplement with iron instead of like maybe changing their diet. But that's also why I would like to include like the comparison group with people who also eat like a heavy iron-rich diet or like maybe a more well-balanced diet.
Can I just follow up? What would be your control group in this study?
So that's a good question. I kind of had a couple different ideas. Some of the studies that I read were there was like just the placebo, or there was like randomized trial. There's a randomized control trial where they had 3 different groups. So they had people who like ate a dietary group, and then there were people who there was just the placebo, and then so yeah. So I'm still kind of like thinking about that. I think. Either maybe like a placebo, so like there's like no control, people who are already like who are not iron deficient at all.
So for your placebo, you mean that would be a group that you know are iron deficient, but you're suggesting or not suggesting
No,
to take anything?
Because that's I think that's definitely unethical. But I think people who are not iron deficient and who are also athletes. Mm-hmm.
This last question, I love how you outlined this, by the way. I like that you took us through, research question, your limitations, everything. You had your outcome variables, but what do you predict might be some of your confounding factors?
That's a good question. Like things that like will affect, like, I don't know, I think things that like even just finding, that's a really good question. I think like maybe like the diet for sure, especially I know the young ladies talked about even just the diet in general with like type 2 diabetes, so diet, and maybe just even finding like a good amount of actual female athletes here who are iron deficient. So just different things like that. Just trying to actually get participants.
Great. Those are two important ones. And just something to maybe note is if you're taking histories and stuff, you might want to also include medication use because some medications might also impair iron absorption as well. But very good. Yeah, and menstrual history, like Dr. Connolly, that's definitely important, especially because you mentioned the fibroids in our population.
Okay.
But good job.
Thank you.
Thank you. One more question. Are those athletes will participate in professional competitions?
I'm sorry, can you say your question one more time?
Are those athletes will participate in professional competitions?
So will they participate in professional
sport competitions? That's why we're talking that they are athletes.
It doesn't necessarily have to be professional. I'm not sure how it could be like even students maybe who are in like high school or how they, I'm not sure how the school system quite works here, but like back home, like high school students, students who are going to like maybe the collegiate level, so not necessarily like professional, because I think it can affect anybody who's an athlete or who moves their body on a consistent basis.
Okay, thank you. And then I have another question. Are you considering iron pills as a doping for those athletes?
No.
For example, erythropoietin is banned by Olympic Committee because it increases level of red blood cells.
Right.
Iron also will lead to increased level of hemoglobin and the oxygen carrying capacity of the blood.
Okay. That's definitely something to think about. Not my intention, no, to dope, but just to identify, because even if I feel like, even if you're not an athlete, just even though I'm looking at athletes, iron is very important. So I'm not looking to dope, but I am looking to enhance their performance, but not in an illegal way.
How do you think, how long this study will take? Iron pills will act after 2 or 3 months, starting from the beginning of administration.
And I did read that. So I was looking at 6 months to a year to test, but I'm open to however long.
Okay, thank you.
Thank you. No questions. Thank you.
Thank you, Melissa. And now we're going to be moving on to our second set of presentations. So I'll introduce Dr. Axterly.
Great. Didn't our students do so well? Yeah? I'm very proud of them. Thank you guys for all contributing. And thanks for all the great questions and advice that you provided to them in allowing them to take their projects forward. So the next session will include research that is already finished or research that's in progress, and both colleagues and a couple of students will present in this category. So all presenters will flow through, and then we'll have questions for everyone at the end as a panel. So Dr. Maureen Hall, who's from the Academy for Teaching and Learning, many of you may know her, is up first.
Okay. Good morning, everyone. It's a pleasure to be here. So we're presenting this morning a completed research. Let's move on. Yes, and just give you a background. So these are the students I want you to meet. One of them, as you can see, who was the Dr. Lucas Bassett, is now matched. It's really moved on into Kansas City to begin his residency training. He was the idea behind this research that we're presenting today. At that time, he was in semester 2, back in 2019, when this thought came to fruition. So I'm saying that to say this: it takes time, it takes persistence and endurance to have a complete research. And so as we progressed, we recruited not just participants, but we had to recruit investigators. So We had Yoshi Chan. She joined us then at that point. And then another point, which were the last two persons that joined the research, we have Michelle and Zach. And they are currently, as you can see, they are co-authors, but they are currently preparing for their STEP exam. Okay, let's move on. So the reason why, how is it that Lucas came to me at the time? We always had our mentoring program, and so many times as the part of the ATL, we have referrals. I would have referrals from students, from the mentors of students who I can help and further support, and Lucas was one of them. He came for support, and at that point, he was referred because he had this idea, research he would like to begin. And the reason why it interests me, because his idea was something that we did not have an official or evidence-based advice to share with students, and that was, at what speed do you actually listen to the lectures? Is it appropriate to listen at 2x? Is it appropriate to listen at 1.75? And really, in the ATL at that point, we had no really official evidence-based answers for students. So these are some of the questions that came to mind. And so Dr. Bassett, at that point, he did the research, and it was quite interesting of our findings. There was just paucity of information in the literature for us to use. What we did find, though, that there were no differences when students used 1.5, 1.75, or 1.25. There were no differences in the ability to maintain or understand the content, and so that was quite interesting. But there was a difference because the studies that we saw did not really align with what we do here. First, the lectures were only 20 minutes. Our lectures are 50 minutes long. The lectures did not really have that in-depth according to the volume of material that we use in medical school. So there were quite some differences. And besides, our maximum speed was actually 2, and we didn't find anything in the literature that gave us advice as to what, if you're listening at 2x, what is it? Is it a good thing? Are you going to have a problem? Is this going to decrease in your memory retention? So that's what prompted us to advance our research. So just on the literature review alone, it was so interesting, we decided, no, this is quite some interesting information. And then it was more like a technology type of research or investigation. And so with that information on the audio speed, we were able to create or establish an abstract. And that was on a technology base. So the technology. So the first abstract we submitted we didn't even start the research yet. But it's just looking at what the literature had out there, and that helped us to find where was the gap in the literature. So at that point, back in 2021 now, we were able to submit an abstract to our research day, but that was not successful. It was not accepted. So later on that year, we submitted to the Association of Medical Education in Europe conference in 2021, which was, accepted. It was accepted for e-poster presentations, which we participated in. We were awarded scholarship to participate. It was 3 of us. 2 of the actual co-investigators were sponsored. We got funding so that we can present. The links are still available now for the conference, which is posted in the toolbox for the AME conference. So we were very excited. So this was a little milestone along the way. It excited us, and we kept going. And so then, there it is, technology. We were accepted. And we presented this, and that was a great accomplishment. We were all excited to carry on, and so we did. We got recognition from the Ross News Pulse newsletter, just exciting and celebrating with us. So what then was the objectives? What did we look at? What was our theme? And I have here the research objectives. What did we do? How we work it through? One of the challenge we had was try to figure out what would be our appropriate N. In the research we did, most of the N's were less than 50. And so we were thinking, man, we're just gonna open this up to everybody, semesters 1 all the way through semester 5. So our advisors at the time told us, no, you can't get too carried away. Maybe we should look at something more reasonable, and that will work. And so our plan was just to use this group and just use 1.5 and 2x as the group. So the 1.5 is the control, and the 2x was really the one that we were measuring. So what were our hypotheses? Well, we felt that, we think that those students who are listening at 2x are doing a disservice to themselves. They shouldn't be doing that. It was our thought. And so, of course, the null hypothesis was just the opposite. Of course, we were surprised. But before I tell you what the outcome was, so the research questions is at what speed the 4X and 5C semester students is safe to listen at their lectures at and not be at a loss of losing their concentration ability or the ability to comprehend the content at such volume and at such depth. So what did we do? We had a pilot study, and that started in 2021. And the first cohort of students was just an N of 31. It was very, very hard. This was during the time, as you know, just in the COVID time. And so we were surprised, even with incentive, it was very hard to pull the semester 4 and 5 students. So we were competing against minis, we were competing against preparing for the comp, we were competing against a lot of things. And so it was a struggle trying to get those numbers up. So we would have like a good response and students signing up, but then when the actual activity came, because the curriculum was very packed, we would have to do some of our events on the weekend. So that was a lot to ask of students. We would start at noon. And so it was a very challenging time to bring those students together. But we continued. We kept on going through. And so when the students came, we would have them in a large group, give them their pre-quiz and their pre-concentration task. We'd then divide them into 2 groups, 1.5 group and the 2.x speed, and then we will have them separated. Go ahead, watch, without adding too much notes or things like that. We would allow them to do that, and then they will stay separated, and then they will do the post quiz and the post concentration. And if they completed all of them based on the research or based on the surveys, they would then be given the award, which was at that time anywhere between $40 to $50 US dollars for the Amazon gift certificate. This is what we found. There was no difference. And that was a surprise to us. There was no difference in the pregame. There was no difference in the pre-test between. Now, this is not within the group. This is between the 2 groups. So, of course, there was some inherent differences in the groups. But between 2 groups, overall, it was not significant. This is just a data sheet that we have of one of the combined cohort. And the first cohort is a different table that we're using. Again, it just shows you the data between the 2 activities that we participated in. And again, it aligns that there were no differences. So just briefly, you would see that we accepted the null hypothesis to our surprise. And so when this came about, I recently found that some of the resources that our students use do go up to 3x, right? Anybody? Yes, right? So I was shocked. Boards and Beyond goes up to 3x. And so, that's no wonder why we didn't see the difference, so we would have had to go further. 4x. There are some resources that even went up as far as 5x. Can't understand anything like that. So it'll be interesting for future to see where there is a decline. And we know that it is somewhere, but I can tell you, I was very happy because as a result, I'm now able to have us in the ATL, we could comfortably say It's okay if you want to listen to 2X. It's okay. All right? It's all right. You're fine. Let's move on. Carry on again. Yes. So what are some of the messages we're taking away from this? What did we learn? So it's less likely to be diminished if you listen to 2X. We can't say that for anything above that, but we do have the data, and we did have the support from our students to help it. And when those students were recruited, they were very excited, wanting to know what the outcome will be. So those were the students who really participated because they were listening above the 1 or the 1.25 X speed for playback for their lectures. So where are we right now? Our work is completed. It was a hard, almost 4 years, but our work is completed. So what we did, we collected a set of journals, medical educational journals, of course, and we selected this one, which is the Biomedical Central, BMC Medical Education Journal. And so far, we submitted this. This is just April. We submitted it. We've been through, we're on our 3rd round of revisions. So the thing is, you just have to get used to understanding that, there's some things you just don't see. So I think this forum, and I give credit to this Office of the External Affairs, Dr. McIntyre and Dr. Arthurley, for doing this, because I was saying right there, I wish our students had this to do, because we would have caught a lot of things that we're catching now as we do the final manuscript. And we go through a manuscript, which is a very tedious process of the editorial process for peer reviewers. And so you get this back. So now we have two minor revisions to make, and we'll just be waiting on the notice of acceptance for publications. That's it. I want to say thank you, because you see the team, the IT team here, they're marvelous. We use them because, at that time in COVID, there were a lot of times we had to we weren't doing this face-to-face, and that's what made it challenging. So we had to do all this online, and the IT department was very supportive in helping this, and all the other departments, the research and so forth. So I just cannot say this without giving them recognitions and thanks, and of course to you today to hear what we've accomplished so far. Thank you.
Great presentation, Dr. Hall. Next up, we have, as I said, questions will be at the end as a part for everyone together. Next up, we have Asfa Alvi.
Good morning, everyone. All right, so my name is Asfa. As you may know, I'm a 3rd semester medical student, and my project was on prenatal care for Native American Alaskan women. Specifically, I did a qualitative study and looked at their narratives of their prenatal care experience. So just an outline. One. All right, so what is prenatal care? So as many of you may know, prenatal care, also known as antenatal care, consists of a series of checkups throughout the pregnancy. It consists of, meeting with the doctor routinely to ensuring that the mother is having a healthy pregnancy, checking their vaccines, immunizations, making sure that they're taking their proper nutrition, any supplements that are needed, and making sure overall the woman is having a healthy development of the embryo. And it consists of both the mom's health and, of course, the baby's health. Now, without prenatal care, women are 7 times more likely to have premature babies and 5 times more likely to have fatal births. And this, can include birth defects, low birth weight, gestational diabetes, there's a series of complications that can go wrong. And I know semester 3 just had their repro module, so it might, bring to call that there's a lot of complications that, women can face during this time. The first trimester is also when, it's crucial for a woman to be consistent with their nutrition. That's when the baby's organ systems is being developed. So this is when a woman is most vulnerable to anything going wrong, right? So that's why prenatal care should be started, first trimester, and that's why I decided to focus on this specifically. Now, disparities in prenatal care. So I looked specifically in the US, and I looked at the first trimester initiation rates, maternal and infant mortality rates, and the adequacy quality of prenatal care. Now, in the US, I looked at the statistics, and they show that women of color have a significantly higher maternal and infant mortality rate compared to white women. And this is attributed to multiple different reasons. But while I was doing my research, I initially started off saying I want to look at women of color. However, I quickly realized that that's a lot of people, right? So I looked at the different ethnicities, and there's a lot of research done on Asian women, a lot of research done on Black women. But one population that came to focus was the Native American and the indigenous population, which makes up 2% of the US population. However, there's a lot of lack of research, they're a very understudied, underrepresented group, and often misclassified. Like, if you say, oh, I'm a Native American or I'm an Indian American, that can be, confused with like Asian Indians, right? So overall, I looked at their statistics, and there is a significantly higher maternal infant mortality rate for these women. Current literature shows that there's almost a 20% difference for when first trimester initiation rates happen. So like I just mentioned, the first trimester is up from like 0 to 13 weeks. And women will delay their beginning, and women don't find out that they're pregnant until 3-4 weeks in, right? At that point, you're already approaching the halfway of your first trimester. So making sure that you're beginning your prenatal care is crucial for that development of a healthy pregnancy. So that was significantly lower for women of color, and specifically the indigenous group. Next slide. So hopefully I was able to cover why I chose prenatal care and why I chose this population of women. So now I'm going to go into why narratives. But before I go on, I just want you, it's not an open-ended question, just want you to get something that I want you guys to think about in the back of your mind. When was the last time you spoke to a pregnant individual about their pregnancy experience, and what came up in that conversation? Now, this is just so I can, put you guys in the right mindset of thinking about what it means to, experience pregnancy. Now, obviously, sorry, men, and sorry, everyone who is not a mom yet, but in this, the reason I have this is so that I can get you in the mindset as, doctors in training. We need to be able to put ourselves in our patient's shoes, and that's going to be very difficult if you don't know what they're experiencing. So next slide. And I really like this native, when I was researching this population, I really enjoyed, interacting with these people, because they have such it opened up a world to me, because I didn't understand, I didn't know much about the Native American population, to be honest, until I, started my research. And this is just a quote from one of the narratives that I got. We don't talk about birth until someone actually gets pregnant. And that, I think, summarizes what everyone might be thinking. You probably can't think of the last time you spoke to a pregnant individual. At least I couldn't when I was doing my project. And it's just going to show that it requires, you to have an open mind. Next slide. So my project itself consists of stories, and that's why, I focus on narratives. I was able to reach out to this organization called Changing Women Initiative. This organization has, they interview, and it's a supportive organization that helps Native American women for different healthcare outcomes, or for different healthcare problems and challenges that they may be experiencing in getting their care. So specifically, there were 7 women that volunteered, and they were able to share their pregnancy story it was supposed to be like a video series. And I was able to transcribe those videos. I even spoke to a couple of these women, and was able to look at their narratives. So the actual narrative itself, I was able to transcribe them. And then after I had the data, I was looking at how can I analyze this data. So, and obviously it's qualitative, and there's no numbers that you can put on, this kind of information. So the way I looked at it was I looked at it in narrative elements of time, space, frame, and themes. Time was more so, for example, first trimester rate, when did they initiate their prenatal care. Space is the location, access to healthcare, were there any barriers physically for them, of getting their medical care. Frame was more so context. Was there any context to the woman, her experiences, specifically, that pertained to her case? And then themes, overall arcing themes that I noticed in there. But before I even go to the results, I want to explain one thing that I actually had to learn about myself before I could even go on. It was the fact that I myself had to unlearn and redefine a lot of the things that I was coming across. And you'll see some of the examples there. But a lot of the practices of your patients are not going to make sense to you sometimes. And when I was reading about these women, when I was speaking to these women, I think this quote really summarizes and sums up what it actually means to be a doctor sometimes. all the things you'll need to unlearn to be a halfway decent person. And I think that's because, we learn patient-centered care, we're learning about physician competencies and what it means to be a good doctor, but I feel like it doesn't get to the root of actually connecting with your patient, so that when we go in there, you need to understand what your own biases are. You need to understand what your perspective is before you can attempt to understand them, because you don't know what lens you already have in front of your eyes before you begin interacting to them. Our bodies are built so that when you enter this room, you already had, some sort of preconceived notion about everyone here. And if you're not aware of your own biases, you'll be looking at that, all these people in that lens. So in a room with a patient, I think this really applies. Next slide. So in terms of actually analyzing it, the first narrative that I have example here is I had to wait 6 weeks to be seen, and it was my first pregnancy. So this is just an example of one of the transcripts. This is by Rayanne Herrera. She was, this is all based in New Mexico, Arizona, southwest, the US states. So just a way, so in my data, I explained how this is a way of looking at the narrative through a time lens. And then the frame, it was her first pregnancy, so this is contextualized to her. This requires education, right, for a first-time mom. And then a second quote that came up was, I didn't want to be in one place and my son in another. I made demands in my birth plan. So that was one of the reasons why I came up with space, because I saw this as a common theme that came up with the narratives. Women were asked to, once the baby was born, I'm sure one thing you might know about is the touch to touch as soon as the baby's born. You want skin to skin contact with the mom and the baby. And that was often not happening for whatever reason. The baby was taken away. And this is actually something that's very, very important to Native American and this culture, these people. So that got to her really personally. I wasn't able to have that skin to skin, saying that there was a medical reason, but whatever it could have been, maybe you could have done it in the same room. Another example was, I remember going to my prenatal care visits and seeing random doctors and midwives. The male doctors made me feel cheap and violated. I think this is really profound, because I feel like this goes back to what I was saying earlier about how when you enter the room, it's just you and the patient. It's really crucial to understand what you might be saying, the patient might not be perceiving it in that way, right? And the only way you can actually improve that experience is making sure that you are well aware of how you are coming across, right? And that can only happen if you know yourself really well. So I think it goes back to medical education. She didn't know much about being pregnant, so that goes back to educating your patients, asking them what do they know. Another quote here is, to explain my birthing experience was difficult. As a woman, I silently deal with my aches, pains, and sufferings. I am conditioned this way. I think this is also really profound as well, because when you have a patient come in, you might ask the patient, do you have any questions? Do you know anything? These things, it's really necessary for you to ask your patient, do they understand? And actually ensure, make sure you go the extra mile to, understand, to make sure that they understand what it is about their healthcare that they might be missing. Next slide. This is an example of education. So this is one of the providers was recommended to see a doula. A doula, does anyone know what a doula is here? Raise your hands. Couple people, okay. So a doula is actually, it's kind of like a midwife, but not exactly. They're not trained to actually do the actual birthing of the baby, but they provide birth support during pregnancy and labor. Oftentimes they do use some holistic medicine medical approaches, having the proper breathing techniques, various things that, for breastfeeding, it's a skill. So all these things, they just educate you about it overall. So this is, I included this because, sometimes as providers, you might not be able to, because of whatever barriers you might have, the systemic healthcare barriers that we providers will also, encounter. I think it's necessary that we also provide alternatives to our patients and advocate for them when it comes to making sure that, they're getting the proper care that they want. And all of these things, they, ultimately affect the quality of care that the patient's receiving. Slide. This is actually a picture that I wanted to include. Nicole Gonzalez, she's actually the founder of that organization, Changing Women Initiative, and she was the one who I was in contact with when I was doing my research. And so this is overall a work in progress. I like this quote. It's actually from the organization. We seek to renew cultural birth knowledge. And I think the point that I was trying to make with my project is overall, as providers and student doctors in training, it's important that we look at stories. As people who have their heads in books all day long, we're not able to, go out and interact with patients, actual patients, where we're learning about them and mastering that skill. That skill is probably going to happen with practice. But I think one way that we can begin doing that work now is to look at stories of patients. Like even just, I hope I can, with the narratives that I chose to share today, you were able to look at, how we can implement and learn from patient stories and implement them in our practice when we're actually out there doing the work. Another thing that I wanted to emphasize on is patient advocacy. Whether or not we're actually in the field, yet, I think patient advocacy is something that we don't get to choose. When you choose this career, you have signed up for patient advocacy as well, because if you care about quality healthcare and providing that quality healthcare, sometimes you won't be able to do it, and it's necessary that you have other options that you can actually fight for your patient. And lastly, just knowing your own biases, that I hope I was able to also put through. So, thank you.
Thank you. Great job, Asfa. Next, we have Mary. She's a semester 3, am I right? 4. Oh, yeah, you're a semester 4 student. Thank you.
Good morning, everyone. As previously said, I'm Mary Bañez, and today I'm going to present the 5-case review for fluorocarbonless repair of giant retinal detachments. I want you all to imagine that one day you are walking around, minding your own business, and all of a sudden you see flashing lights, characterized sort of like shooting stars. Then you see the presence of new floaters, and all of a sudden you see a gray-black curtain cover part of your vision. What you have just imagined is what a person or a patient experiencing a giant retinal tear sees. The anatomy of the eye is quite simple. Here, as you can see by the picture on the left, you have your cornea, your iris, your lens, your vitreous chamber, and behind it, which is the focus of my study, is a retina. In this picture, you can see that there is a retinal break and a retinal attachment. The retina is a thin layer that's extremely delicate, and it lies above the retinal pigmented epithelium layer. When you experience a retinal detachment, the retina separates from the retinal pigmented epithelial layer, so the layers of rods and cones and all of those layers above separate. This makes it an urgent medical emergency that needs to be surgically repaired as quickly as possible to prevent further degeneration of all of these layers and try to restore vision as much as possible. Giant retinal tears are circumferential retinal breaks of 90 degrees or more. As you can see by the picture, the white tissue is the retina, and it has a giant tear, and it has inversion, which means it has folds. Behind it, what you see that's orange is the retinal pigmented epithelial layer. Because of the urgency of this situation, you need highly specialized vitreoretinal surgeons to perform this procedure. Patients that experience giant retinal tears are as following. Most common is highly myopic patients, which means that they have an eyeglass prescription of -5 or higher. Idiopathic, which means that it occurs spontaneous without any known reason. Blunt force trauma directly to the eye. And in very rare cases, congenital vitreoretinal dystrophies. This current standard of care, especially in the United States at this moment, is the use of perfluorocarbon liquid. Perfluorocarbon liquid is a heavier than water liquid, and it is an intraoperative device. This means that it needs to be injected in, but also removed. It uses the force of gravity to displace all of the fluid in the retina and the retinal tissue so that it goes back into its correct place for later laser therapy. In this picture, you can see an example of a perfluorocarbon liquid that is currently on the market in the United States. Okay, in this video, thank you. A vitreoretinal surgeon is actually performing a repair of a giant retinal tear. The white flap is the detached retina. And what the physician is injecting is actually the perfluorocarbon liquid. As you can see, it has a heavier than water quality, and it'll eventually go so much that it pushes the retina back to its original place so that it later can be treated with laser therapy that creates scar tissue to kind of seal it in its place. But the issue with perfluorocarbon liquid is that, as amazing as it is, it needs to be removed. Perfluorocarbon liquid is actually costly. It costs around 160 USD per vial, which is necessary per case, and it is not without risk. There's an increase of 11% of complications, specifically retained subretinal perfluorocarbon liquid, that occurs in these patients undergoing this procedure. As you can see by the picture on the left, it's an optical coherence tomography of a normal fovea and retina. And on the right, you can see the same OCT of a patient with retained subretinal perfluorocarbon liquid. As you can see, there is a layer of liquid underneath the retina, and it is kind of trapped. If that liquid, or the perfluorocarbon liquid, moves to the fovea, you can lose total function of your fovea and your sight. And it needs to be surgically removed. So this patient has to undergo anesthesia again, all the payments of having to go through seizure once again, and an even more increased risk of calculations to remove this intraoperative device. My study focuses on using filtered air, using the modified prone position gas fluid exchange technique. Filtered air, as opposed to perfluorocarbon liquid, is already built into the medical devices vitreoretinal surgeons use in their OR rooms, so it's free. It takes advantage of the buoyancy of filtered air instead of the gravity as perfluorocarbon liquid does, and it does exactly what perfluorocarbon liquid does: displaces the subretinal fluid and retinal tissue. This means that there is no need to use heavier than water liquids like perfluorocarbon liquids. You already have this readily available in your OR room, and it also decreases costs. And also, based on the nature of filtered air and subsequent introduction of perfluorooctane gas, there are no complications. Filtered air in this perfluorocarbon gas perfluorooctane gas does not need to be removed. It dissipates in a matter of 6 to 7 weeks, while perfluorocarbon liquid has to be surgically removed. This is why there is a vast decrease in the rate of complications. In the study, we reported 5 cases, which were 4 patients, 5 eyes, that experienced a giant retinal detachment, and it was repaired with filtered air using the modified prone position gas fluid exchange. The median follow-up was around 11 years, and visual acuity was assessed. The modified prone position gas fluid exchange method is as followed. Initially, you have a standard vitrectomy with excision of the vitreous base. And then, as you can see in figure B, gas fluid exchange is put in the lateral decubitus position to correct any retinal inversions. What's interesting about this procedure, as opposed to the perfluorocarbon liquid, that it's a gas, so it rises. So depending on where the tear is and where you need to repair it, the person has to be in that position so that it goes up and presses against the retinal tear. It eventually is finalized in the prone position, and then the patient is returned to supine position for laser therapy and introduction of long-acting intraocular gas tamponade, perfluorooctane that I mentioned previously. This you could see in figure D. The very dark horizontal line is the giant retinal tear, and in figure D, the lines above is the laser therapy. These patients, after undergoing surgery, have a follow-up of 1 day, 1 week, 6 weeks, and 3 months to assess any complications, any visual acuity issues, amongst other things. The results of our study are as followed. Of 4 patients, we had 5 eyes. The ages range from 46 to 59. The third column is the visual acuity before the surgery. CF means count fingers. This means that this patient could not read any of the letters on the eye chart exam. They could only count the fingers in front of their face. This means that they have a vision of 20/400, less than that. The next column is the visual acuity post operation, and post-healing. As you can see, the first patient had a vast increase in visual acuity, while the others more or less maintained their visual acuity. This is the goal for this surgery. The next column just indicates that 4 out of 5 of these patients did not previously have an intraocular lens implant. Only 1 did. This is just important for the physician performing the surgery to know, because he has to modify his approach in initially going into the eye. Location is the location of the giant retinal tear in respect to the optical nerve. Nasal is medial, and you have temporal. And follow-up range from 7 months to 19 years. Of these 4 patients and all of the 5 eyes, all of them went under successful primary repair of giant retinal detachments using the filtered air and the modified prone position gas fluid exchange. With a median follow-up up to 11 years, we can happily say that all eyes remain detached without significant epiretinal membrane formation or proliferative vitreoretinopathy, which means any scarring, and good postoperative visual acuity. This is the goal for this surgery. We want to either increase visual acuity or retain what you had before this break. If this is not repaired, these patients can go completely blind in that eye, and vision is extremely important for day-to-day life. Using filtered air as opposed to perfluorocarbon liquid or heavier than water liquids is a viable treatment alternative. It is already readily available in the machinery these vitreoretinal surgeons already have in their OR room. It is safe. You have a decreased risk of complications because it doesn't have to be removed, as opposed to the perfluorocarbon liquid where it needs to be removed, and you also have retained subretinal perfluorocarbon liquid, which increases the risk of complications. It is also very cost effective. As I had previously said, filtered air is free, and perfluorocarbon liquid in the US market can range around 160 USD per vial and case. The use of perfluorocarbon liquid brings about additional operating room costs and is not without risks. Retained subretinal perfluorocarbon liquid will create postoperative challenges and increase the rate of complications. In the current climate of ever receiving surgical reimbursements, the added costs of intraoperative adjuncts cannot be ignored. Therefore, perfluorocarbonless repair for giant tear retinal detachments is a safe, viable, and cost-effective surgical alternative. Thank you.
Great job. Next, we have Dr. Mehta. Is he? Oh, yeah. No?
Good morning, everyone. I'm excited to be here, and thank you, Department of External Affairs, as well as the research team for putting this program together. So today, I will be talking about a telehealth program that we have implemented in semester 4X and 05 clinical skills curriculum. And the focus of this work is to put some data that came from student evaluation of this telehealth program. I will begin with this mission of Ross University. I know that most of us are familiar with this mission, but I want to emphasize on 2 words here, which is innovative and experiential learning or teaching modality that we offer to our students. And this work was presented last week in International Association for Medical Science Educator Conference that was held in Mexico. So I wanted to really emphasize on this mission of Ross University in that conference for the global community, that we are committed to provide any kind of innovative and experiential learning experience to our students. And I believe that this program will definitely fit into that innovative category. So inception of this concept was in the time of pandemic. In March 2020, when there was a suspension of all in-person clinical activities, including clinical site visit here in local Barbados clinics, which was called ambulatory healthcare experience. And we had to suddenly suspend all those activities. Right after that, maybe in a month or two, we in Department of Clinical Foundations started thinking about some alternative program which can be sustainable during that pandemic period as well as beyond. And so in the leadership of Dr. Dyer, who was semester 4X and O5 course director at that time, we started working on this telehealth program. And it took about 9 months because we needed to really procure those devices and we need to test those devices. We need to integrate that with the online platform. We did a lot of pilot studies, we developed lesson plan, and we wanted to make sure that the learning objectives of the earlier clinical activity remains applicable to that new program. So with all that modification and testing and the work of 9 months, and there was a lot of collaboration from other departments, including our clinical department in Miramar and some of the instructional design people from Ethnomedicine. And after 9 months, in about March 2021, we were satisfied that we have this program which can go into the curriculum. And so we implemented this program from summer 2021 for semester 4X and O5 clinical skill students. Most of semester 4X and O5 students may have experienced this program, but if not, that here we have some of the screenshots from those recordings. In the first picture here, we can see that the renal nurse, who is actually at the site in the clinic, is examining or maybe interacting with the patient, and all the students can see what's happening in the clinic. And you can see that there is a device, there is a headset which is worn by that renal nurse. So whatever he sees or listens, that entire experience, clinical experience, is basically conveyed to the students. And this device was really key for bridging the gap between physical and virtual care. So, and the students, you can see in the other screens that the students can also interact with the patient. They take history from the patient. They also perform proxy-guided physical examination where they would just say the steps that I want to perform this type of examination, and these are the steps. And renal nurse would perform that examination and report those findings. So student had that consultation experience with a real patient who were undergoing dialysis treatment. And then after that, students would also have the clinical tour of that entire clinic. They would experience how the dialysis machine would work. They can ask any questions to the facilitator as well as to the renal nurse. And at the end, when they have the clinical information of the patient, they would present their SOAP note, subjective, objective assessment and planning, SOAP note, to the facilitator to receive formative feedback. So it was really a kind of very valuable clinical experience and a lot of educational value for students. And so we were, right from the beginning of this program, we were interested in looking at the evaluation of this program, that how well this program is working. So we started looking into different ways of evaluating this innovative program, which is telehealth program, in the medical curriculum, which this is basically program that was provided to the students for learning. This is not the telehealth or telemedicine consultation for the patient. So we wanted some rubric or some checklist that we can use to evaluate the program. Unfortunately, we did not find any. So we created our own evaluation kind of rubric that may be applicable for this telehealth program. And so we decided to look into the 6 different domains that you can see, beginning from learning objectives and outcomes, learning environment and educational strategies, and so on. We collected data from spring and summer 2022, and the data came from number of sources. Like we had student evaluations, and those evaluations had 17 items. 15 of them were Likert scale item, and 2 of them were like open-ended question for free text responses. And we also had students completing pre and post activity quizzes. So we also collected data from that to address the 4th category, which is educational content and value. I know that this slide looks really busy, but you can see that this is the student evaluation questionnaire, survey questionnaire, where you have 17 questions. And first 15 questions are Likert responses, and last 2 are open-ended questions for the free text responses. For the research method, we did the mixed method study, so we had qualitative and quantitative data. For that, we used descriptive statistics as well as t-test for the pre and post test. And for the qualitative responses that we received from open-ended questions, we used framework analysis method to categorize all the data snippets and then try to analyze what are the emerging themes coming from those remarks. So this slide is talking about domain 1, learning objectives and outcomes, and we really have very encouraging results coming from the students that this program in fact is meeting the intended learning objectives, that students were able to interview patients, students were able to perform physical examination and so on. Next, the domain 2, which is learning environment and educational strategy. Here also we had good results, but at the same time here, the question 8, where it talks about the transmission quality of that program, there were some concerns, and we did experience some initial hiccups with the audio and video qualities. And at that time, if you recall, there were some issues with the Zoom platform, that we were not allowed to use the Zoom platform for this activity, and we had to use Microsoft Teams. And so students did experience some audio-video challenges as well as the internet connectivity issues. I believe that that aspect has been improved, and we did some adjustments by improving internet connectivity at the clinic and so on. Domain 3, students' preparedness and engagement. Again, most of the students really enjoyed this program. They could experience the value of this program. They felt that they are involved. It's very much interactive, and they had a lot of things to learn from this program. Educational content and value, again, most of the students enjoyed this program. They felt that they learned a lot. And in our curriculum, we have renal module in semester 4. So most of the students had renal module before experiencing this dialysis clinic. And so that was also helpful because they had something to build upon their existing knowledge. When we asked that whether they would like more Telehealth session in the curriculum, we can see these results here, that 34 or 35% were clearly, strongly agree they enjoyed the program. And many of them in the free text responses mentioned that we would love to have cardiology clinic, or we would love to have some other specialty clinic Telehealth experiences. Here are the results from pre and post activity quizzes, and based on these numbers, we see that there is a huge difference in students' knowledge about end-stage renal disease, about hemodialysis, and so on. Domain 5 was patient's perspective. Most of the students felt that the patient was really comfortable interacting with the students because there were like 15 to 18 students in every session. So there were like, each student are supposed to ask like 3 questions to the patient, and then the role will change. So we really wanted to make sure that the patient feel comfortable by this many questions in 10-15 minutes time. And finally, our analysis from the qualitative results, we can see that some of the themes that came from all the free text responses, and I have listed some of them here, which are like most recurring themes. And you can see that we received a lot of data about the strength of this program. And also, we did find some of the themes which are kind of areas for improvement. Most of the students liked the experience of interacting with the real patient, learning about the dialysis, comfort of having the tele-ACE or telehealth experience. They also valued that the telemedicine and telehealth is going to stay and even expand in future. So they really enjoyed that experience right in the preclinical courses rather than waiting until they go to the clinical sciences. Many students also indicated that they would love to have a focused pre-reading material. So currently we are also thinking about that whether we should make it available or not. And The purpose of this program is quality improvement. So we did some of the minor changes into the program after implementation. For example, we included one additional break into that 3-hour session. Initially, we had one break, and now we have 2 breaks. Breakout rooms, we started with some breakout room. We are continuing with the breakout room so that students have opportunity for making their SOAP note presentation individually, even if there are like 15 or 18 students in a session. We did realize some of the technical challenges related to audio-video platform as well as the headset, and we did some technical solution for that. For example, there were some comments that the video frame is not appropriate, or video is not focusing on the machine, or video is not focusing properly on the patient. So what we did was we involved colleagues from AV, IT, simulation specialists, and we did some marking on the floor that the nurse will stand exactly here for this part of the experience. And so that would help students to have consistent experience for different sessions and so on. For the faculty bandwidth, we did the collaboration between preclinical and clinical departments. So because we would have about 5 or 6 breakout rooms in every session, and so we would need 6 facilitators. So in addition to having our colleagues from Barbados, we had colleagues joining from even Miramar campus of the Ross University. We did have some logistics issues for the scheduling, so now we have meeting link or the session link added into the metrics schedule, so it becomes easier for students to know that where to click to join the session. And as I mentioned about the pre-reading material, that we are currently working on that, and hopefully we will have some focused material for the session. So in conclusion, I think that the Telehealth program was really successful in meeting our intended learning objectives, and students highly regarded this program. So with our experience of developing this program, I can definitely say confidently that with planning, with collaboration, this is definitely possible to design the program and implement it in the preclinical sciences. And when I did the literature search for this research study, I can say that by the end of year 21, we are the only university to have this kind of telehealth program in the preclinical science curriculum. I have found some of the data where we have similar programs in the clinical rotations, but I could not find any medical university anywhere who can have this program in the preclinical sciences curriculum. So we are really proud of having this innovative program in our curriculum and really great offering to our students. Thank you.
Our last presentation in this session is by Mariana Shepherd. And then after that, I'll open the floor for some questions.
Okay, hi, good morning, everyone. I think I would have racked up some nerves listening to all of your great presentations so far. My name is Mariana Shepherd. I'm the Administrative Assistant in Semester 4 at SO5. And I am, Administrative Assistant Semester 4 at SO5 under the leadership of Dr. Dyer and Ms. Claire Joseph. However, today I stand before you as a postgraduate student in the Faculty of Medical Science, Department of Pharmacology at the UWI Cave campus. Today I will be presenting my project to you, and as you can see on the screen, the effects of the herbal treatment on the HPG axis and the KNDY neuropeptides in experimental induced PCOS rats. All right. Whew. All right, so first, what is infertility? And as it stated, this project is geared to infertility. The CDC defines infertility as not being able to conceive after at least a year of unprotected sex. And there are many reasons for infertility. Some of that would be imbalance or actual physiological barriers, either from the male's end or from the female's end, or both. All right, so I will be specifically looking at PCOS, which many of you probably heard of, polycystic ovary syndrome, and I'll go on to speak about what that is. Polycystic ovary syndrome is one of the most common endocrine disorders amongst females that may lead to infertility. At present, it is one of the most concerning endocrine disorders and affects at least 6 to 20% of reproductive aged women. Here in Barbados, we have seen a decrease in our birth rates, and a lot of that have been chalked up to economic crisis and women deciding not to have children. However, I believe a lot of it has to do with many disorders, especially as we have diabetes present on the island as well, which then leads to obesity. So there are some symptoms of PCOS, but they are as a result of one, insulin resistance, and hyperandrogenism, which is meaning an increase in the testosterone in females. All right, at present, there is no set cure for PCOS. Any treatments given are given based on a symptom-by-symptom basis and based on the female and where she's at in her path in life. So, for example, if you have a younger female, she'll be given birth control pills as a form of balancing her irregular hormones. If the patient is obese, they may be given metformin. And for those women who are higher age or are married, they may be given Femira or Clomid as to assist with their infertility, increasing their chances of being pregnant. So the drugs that you would have just seen just now are not set for infertility. As I would have mentioned, metformin, which is used for diabetes patients. We have Femira or letrozole, which is used in breast cancer patients. And yes, Clomid have been specifically developed for fertility. Okay, so for my study, I'll be looking at herbs, and I'm probably wondering why. I heard some students speaking about herbs. So this project leads into drug discovery. And so in here in the Caribbean, we are known to use herbs for almost everything. If you do have a grandparent, they'll also have a herbal remedy for any issues that you may be having. However, what we do, the issue in our medical arena is that we do not know how a lot of these herbs work and the side effect of these herbs. And so this study basically looks at herbs that are being used across the Caribbean or across the world specifically as supplements. And if you as women look at your supplement bottle, you'll see some of these herbs at the back. But how does these herbs work and how do they specifically address the issue? All right, so before I move on, most of you are from the medical arena, so you are aware of the female reproductive system, and it starts with GnRH. Well, we assume that it starts with GnRH from the hypothalamus, which means when that is released, it signals the release from the pituitary gland of FH and LH, which is follicle-stimulating hormone or luteinizing hormone. This then goes on down to the ovaries and signals a release of many various hormones that controls the reproductive cycle. So based on this diagram, we do know that the HPG axis consists of the hypothalamus, the pituitary, and the ovaries. Okay. So with women who have PCOS, what we would find is that at certain parts of the cycle, so let's go to normal, at certain parts of the cycle, you would know that there is a peak in luteinizing hormone, which then assist with ovulation occurring. For PCOS, women, that does not occur, and you have a varying ratio of LH and FSH, and therefore that woman she does not ovulate regularly. What happens is that the follicles which are to be released actually stays in the ovaries, and that's where we have the characteristic of PCOS, the polycystic ovary, a chain of pearls basically can be found around the ovaries. So for my study, instead of starting at GnRH, which everybody knows to be the king of the reproductive cycle, I wanted to look at what actually controlled the GnRH, which is known as the kisspeptin neurons. I'm not sure how many of you have heard of them, the neuropeptides. And so I'll be looking specifically at kisspeptin, didarphin, and norkinin, which actually controls the pulsation release of GnRH. And so yes, this slide basically just shows how the neurons are connected. And for the neurokinase B, that actually stimulates the production of kisspeptin. And for the dinorphin, that actually decreases or inhibits the production of kisspeptin, which then controls the release of GnRH in a pulsation manner. So getting into my study quickly, you did hear the title already. So my aim is to determine the effects of the herbal treatment, that should be treatment, on the HPG axis and the KND neuropeptides in experimentally induced PCOS female rats. For my research question, again, all of these are linked. What is the effect of the herbal treatments on these KNDY neuropeptides, the receptor expression, and the various levels of reproductive hormones in the PCOS female rats? And my hypothesis, of course, I have an alternate and a null hypothesis. So I'm thinking that hopefully I can see a correction of the hormonal imbalance caused by PCOS from using the herbal treatments. Or for the null, we may not see any effects to the KNDY neuropeptides or to the receptor expression and reproductive hormones. So my objectives, I am currently in phase 1 of my study: extract the herbs from their natural form, prepare the herbal extracts. I'm screening the cocktails, which is a mixture of the herbal extracts for mechanisms and dose responses using cell lines. And the last part of phase 1 is to obtain the IRB approval and authorization to carry out phase 2. So phase 2, I will be using a representative of animal samples where I will induce PCOS in female rats, and I would use baseline hormonal levels to determine if there is a difference after the post-treatment of the herbal cocktails. I am also hoping to identify new pathways relating to the formation of PCOS, and if we do happen to get new compounds that can assist with further drug development, that would be great. All right, so I do have for my next part, we're going to look at the methods. And so essentially these herbs were purchased already. What you're seeing is that I have feature tanks because that's how I wrote my methods. However, the herbs were purchased already and they were milled, and then they were extracted using 70% ethanol. I did use 2 forms of extraction processes, which is maceration, where you soak the herbs, and the next one is oxalate extraction, where there's a little bit of heat involved to get as much as the extract out from the plant material. The marsh, which is the remaining plant material, was placed to dry and weighed, so I can have an idea of the percentage of extract that I would have obtained from doing the extraction procedure. The ethanol, which was used as a form of a vehicle to drive out the extract, was separated using a rotovap. This separates the ethanol from the herbal extract, just leaving me with the extract to work with. This is just a few pictures. That's the mill that we would have used in the lab. Those are the herbal extracts. Unfortunately, I cannot reveal the names at this time in my study. All right, and this puts me on to phase 1, where I've done the extracts already, and this is the current phase that I am at. So I have obtained my hypothalamic cell lines and my pituitary cell lines, and right now I am working on cytotoxicity assays. This is basically what some of the other students were speaking of. How do we know these herbal extracts are good for the body, what they're doing? And so basically we're carrying out cytotoxicity to see how toxic the herbal extracts are before even introducing them to the animals, due to various ethics and various protocols and procedures. Following the exposure to the herbs and the cytotoxicity assays, I will be able to develop a dose control curve, which will tell me what concentrations and what times of exposures are ideal for experiments moving forward. At the end of the last slide, yes. So basically, for this part of the experiment, I will be carrying out a series of ELISA assays, which is basically to quantify any changes that I will see. I'm looking at the regulation of receptors. So is there increase, a down or up regulation of receptors in response to the herbal extracts? Is there activation of receptors? And is there a change in secretion of hormones in response to the extracts? All right, so for the hypothalamic cell line specifically, I'll be looking at the candy-way neuropeptide receptor expression, and I have listed the receptors there. If you've probably seen them in some of your lectures, pharmacology lectures. Based on the first part of the experiment, I will determine which concentrations are best and time ranges are best. And I will be checking to see if any of those extracts had any activation to the receptors, which will then tell me if those herbs play an important role in the activation or process of treating any form of PCOS at this point. I'll be using variables as it relates to these studies. So I have purchased agonists, and basically an agonist is the hormone that is known to activate the receptor. So I'm able to compare against that and identify whether or not the herbal extracts did have any change on the cell line. So moving quickly to that. Pituitary cell line. Essentially, for the pituitary cell line, this is a secreting cell line which actually secretes LH and FSH. And with that, I'm able to see after exposure if there was a change to the if there was a change to the secretion of LH and FSH in response to the extracts. So moving on to the phase 2 of the study, animal study, which we are now prepping for. I will be beginning scrubdali female rats, and we will be inducing PCOS. This will take us at least a month to do. And I do have 5 groups that I'll be looking at. My normal, which will be the control. These are rats who will not be induced with PCOS. My negative control, which will be PCOS-induced rats, but treated with saline. And we have my positive control, for which I'm using a drug which is known to work already, which is metformin. My group 4, I will be using my herbal cocktail, and the herbs that I will carry forward into phase 2 will be determined based on the results from phase 1. My 5th group is where I'll be looking at a combination of both the modern medicine metformin along with the herbal treatment, for which there have been studies that show that they have been effective usage using herbal supplements along with regular modern fertility medication. I've done my sample size calculation already, and we've ended up that we'll need 9 rats for each group. However, we will be purchasing additional in the instance that there's any death during transport. These are the hormone levels that I will be looking at, the various parameters that I will be measuring from blood samples taken from the rats, and this is before and after exposure to the various herbal extracts. Now, in order to take these hormone levels, I will need to monitor the cycle in which the rat is at. So I would need to do vaginal smears of these rats to identify what part of the cycle they are at when we're taking the hormonal levels. Okay, so this is just an idea of my methods. Essentially, I'll be getting the rats. They'll be placed under quarantine for 2 weeks to ensure that they're safe. We will be exposing them 4 rats per cage and kept at regular cycle, which is a 12 light, 12 dark cycle. They will be fed standard chow. However, when I'm inducing PCOS, I will be injecting the HEA, which is basically the testosterone, and I will also be providing them with a high-fat diet, which will mimic some of the insulin resistance that we do see across the board. We will be weighing the rat every 2 days, and also doing vaginal smears as well. And I will be taking 3 blood samples because the rats are very small. It will be a risk to take more than too many samples, which may induce anemia in the rats. So I'm only taking 3 samples from the rats, day 0, day 15, day 30, which is basically midway of the cycle and at the end. So just to review part of my ethics, my ethical issues is that I would need IRB approval, which means I have to basically outline all of my procedures. A veterinary member from Barbados will need to review to ensure that I carry out safe treatments with the rats. I have been trained to handle the rats already, and I have done my city courses in order to be able to do so. And in terms of my limitations, Barbados is a very small island, and so it's very difficult reshipping and costs. And so that is one of the limitations. And also another limitation, is that the herbs could not be purchased locally. So everything except for one herb was brought into Barbados. Dissemination of results, I'm hoping to have more opportunities like this one in order to give education about PCOS and bring awareness. As I have mentioned earlier, our birth rate in Barbados have decreased. And if we look across the board and maybe we take a look at the women, we are seeing that a lot of them are obese. Our younger women are obese. Our children are, some of them are obese, which means that this may be a bigger issue going forward. And of course, I will be hoping to publish in various articles, journals, and that is how I plan to disseminate my results. Those are my references. Sorry. All right, those are my references, and I am finished. Thank you.
Thank you, Mariana. I know many people might be surprised to see the work she's doing, and I'm really excited to hear that. I would like all presenters from this last session to come to the front, and we will have a couple minutes for questions. You can sit at the front where Dr. Raditz is, so Dr. Hall, Aswa, Mary, Dr. Meta, and Mariana. And in the meantime, does anyone have any questions?
Right, so I'll start off. Mariana, awesome job. That was really great. You mentioned that you're going to induce PCOS, but how are you going to confirm that the PCOS has actually been induced in the rats?
Yes, please. I'll be taking blood samples to look at insulin levels, because I do expect to see an increase in insulin levels or insulin resistance. We'll also do, which has to be approved by IRB, we'll probably also do a dissection of one rat sacrifice to see if we do see any characteristics after that. The rats are really small, so doing the ultrasound, I may not be able to see effectively anything. So unfortunately, we'll have to sacrifice at least one rat to determine if the others do have PCOS.
Great, thank you. My next question is for Dr. Mehta. I think your study was really impactful. I know you mentioned that the students were saying they really enjoyed the telehealth, but did any of those students ever get in-person clinical experience before being exposed to telehealth?
That's a great question. So this program was implemented from summer 2021. So in that particular semester, we were still online, in online curriculum. So if I talk about that summer 2021, I would say no. Students were completely online, and that was the implementation during that pandemic time. I believe that we returned to on-campus curriculum in fall 2021, and that's when we resumed original AHCE program where they would go to clinic. And also in addition to AHCE, we also had implemented another program very soon that is called AHR, Ambulatory Healthcare Rotation. So we kept adding those in-person clinical experiences as we could, considering the pandemic-related restrictions and the clinical affiliations. But at the same time, with this encouraging student evaluations, we continued with the TeleS offering as well.
Great, it would be nice to see what the happy medium is, mixing the two would be great. Thank you. Dr. Hall, for you. So for me, my baseline is kind of 2x when I teach a lecture. Students tell me I'm the only one they don't have to speed up. So I know you mentioned that you kept the lecture the same, but did you also keep the lecturers the same when you assessed?
That's correct.
And you mentioned that the recruitment rate was low. How did you actually recruit students?
Well, again, at first we were thinking on selecting students from semesters 1 to 5, and then we just limited to semester 4X and 05. We recruited them in multiple ways through word of mouth. We also recruited them by sending an invitation letter to the entire class and give them a little, blurb about it. We tried to incentivize them with the gift certificates. But again, like I said, these students were making a decision, trying to decide, should I study for comp? Should I participate in this research? Should I prepare for my mini one, or should I participate in this research? So those were the challenges we experienced, because our original aim was to have at least, say, about 100 to 150, and that's why we targeted that group, because we would have been able to offer the entire class the opportunity to participate, because the numbers was like at that time 168, so 150 was a reasonable way to have all of those students have an opportunity to participate.
Great. And last one, you mentioned some exclusion criteria. Did you exclude students with attention deficit disorders? And also, did you consider the fact that this was started during COVID and a lot of us were already very drained by looking at the screens so much?
Yes. No, we did not exclude students with the ADHD. The only students we excluded if they did not agree to sign the consent. So the consent was a part of the invitation letter, and so this is all done electronically. So once they opt to decide, oh, this is interesting, I think I want to do this, we allow them to either sign to have that contract electrically signed, and then they were given a baseline survey to tell us, how do you actually listen to lectures? So we had that baseline information. The actual exclusion criteria, again, was those who did not complete did not complete the post-test or the post-concentration game. So those were the criteria that we used to exclude.
Great. Any other questions? Any students have any questions? Dr. Mary James in the back.
All right, thank you so much. And a follow-on from Dr. Date's questions for Dr. Hall as well. Quite interesting presentation. I just wanted to know if it was considered, because I know some students that I speak to as it relates to their lecture playback speeds, they say that the speed varies, as Dr. Date would have said, based on naturally how fast the professor speaks, but also the content and the accent for the lecturer. So I'm not sure if that was something that was considered during the study.
Yes, that was actually considered, and that's why we use that in determining which lecturer we will use. So it was just one lecture for both groups, the control as well as the other group. We use that understanding that, okay, some people are going to speed it up for the content. Some people are going to speed it up because of the professor's accent. And we knew this from the survey and so forth, the feedback that we got. And so we used that criteria to determine we should really use a lecture that is more neutral. It's something that the students are more likely to be comfortable with.
Okay. Any other questions? Dr. Dyer?
Yes. Thanks to all of the presenters for very insightful presentations. And I have a question for Ms. Shepherd and then Dr. Mehta. Ms. Shepherd, again, congratulations on the work that you're doing. My question is, in terms of combining the herbal and sort of scientific aspect, oh, you didn't see the scientific component to herbal medicine, in your work, have you had any consultations, or do you find it easier or more challenging to bring that aspect of the traditional medicine into the fold? Just your thoughts on that, because I thought that was quite interesting, incorporating that aspect into your research.
Okay, thank you for the question. So I haven't had any difficulty as yet. I do have a gynecologist on board, Dr. Damian Bass. So he have been reviewing the study to ensure that I am looking at it from both perspectives. And so I will continue to do so, especially as I go further into the animal study. I am still toying, I know I had indicated metformin. Some of my panel members would like me to consider Femira because it's more fast acting, but we're still weighing the pros and the cons as to which drug to use for the combination.
Thank you. And to Dr. Mehta, you mentioned that you got quite a lot of qualitative data from students, and I know we have students in the room here. Any tips or insights as to how you're able to obtain such rich data, particularly qualitative, which requires a lot of typing, no offense students, but from that side, interested to see how you obtain that.
Thank you, Dr. Dyer, for that question. And I want to mention that this Tele-ACE program, similar to earlier version of ACE and AHR program, was mandatory for students to attend. So all the students who were enrolled in these two particular semesters, most of them attended the program unless they have an excused absence or they withdraw from the semester or something happened that way. And when students do their verbal presentation of SOAP note during the session, they already have their notes and they are also supposed to submit those notes onto CAE platform by 10 p.m. on the day of session. So what we did was we integrated this evaluation rubric along with that submission of the SOAP note. So as soon as they complete the SOAP note, the CAE would take them to the evaluation page, and they are also required to complete this program evaluation on the same day after the program. So I believe that we had 353 students enrolled in these two semesters, and if you see on the result slides, we had data from 346 out of 353 students for the evaluation. And we had about 322 students who completed pre and post, both the exams, both the tests. So we used those numbers for t-test for the pre and post test. Thank you.
Thank you. Take one. Yeah, I have a question. Oh, okay. That's Nan, and then I'll take student.
Yeah, it's another question for Marianne. I'm wondering if you can just explain to me, you said you were going to quarantine the rats for 2 weeks to ensure they are safe. What do you mean by that statement?
Okay, so the rats will be pathogen-free, but when I say safe, and I maybe should have said acclimated to their environment to ensure that they're not stressed. So they're not going to have any pathogens. They're going to come straight from the lab from the US. They're rats that would have been born in the lab, so they had no prior exposure, but just to ensure they were not stressed in any way, which may have effect, which probably will affect the study if they are.
That's great, thank you, that clears it up.
Okay, great. Well, one question from the student, and then I have some from Dr. Fernandez.
Absolutely.
So do you think that would be like a good follow-up research
Yes.
to do?
Yes, yeah. So like I said, so the question actually was actually, she's asking if we would have seen a different uptake or different response if we were to use students from semester 1 as opposed to using students from semester 4 and 05, correct? Yes. So originally we use students in our recruitment from both semesters, all semesters. We wanted to give it an option for everyone. But based on the research that we looked at and the other contributors to the plan for the research, we decided that it would be best to work with a number of 150. And so when we look at the numbers of all the semesters, that semester, when you combine 4X and 05, they were about 168. So that in that cohort, almost everyone would have had the opportunity to participate without turning students away. The reason why I would have liked to use the first semester students, because they tend to uptake a lot of the research activities, and then we'll catch them from the very beginning, where they have 4 more semesters to look at lectures, whereas at the end, they're almost done with it, right? But that was the rationale. We had a good discussion about choosing which group to use. So thank you.
Good question. Dr. Fernandez is asking Mariana, any implications of the study for clinical care? So the role of these potential intervention in PCOS.
Well, I do trust it will get that far, but first I will have to see if there are any. So when we look at the results and we see if there is an effect on the rats, we'll first then have to do some more chemical screening on the extract to kind of separate the specific compound that is given the said reaction. That will then allow us enough evidence to carry forward and request that clinical trials be done. But it's a long path before we get to that because the drug discovery pipeline does take a long time.
Great. And Dr. Fernandez is asking whether there was any indication when the students were using the transcription feature in addition to the playback.
No.
Okay.
They did not use the transcription factor.
Okay.
Yeah.
Thank you very much. One more student question. Yeah.
I have a question for Mary. So in your study, did any of the cases have astigmatism or other irregularities of the eye, or were they just myopic?
So the patients specifically were all idiopathic. So we made the physician specifically when getting all the data together wanted it to be consistent and not just have a range of blunt force trauma, myopia, and idiopathic or genetic concerns that might cause the giant retinal tear. So they're all idiopathic, which means that they occurred spontaneously, and there's no known reason for why it happened.
Okay, great. And last question to this section, Dr. Daisley.
Sure, thank you so much. My question is also for Dr. Hall. I had a question regarding the content of the lectures that the students would have been exposed to. So I wanted to know if maybe this would have been content that they may have exposed to beforehand. And my second question was regarding the timing of the process, how soon after it was done, and also have you considered maybe retesting at a later date to see how much of the content is actually retained?
Okay, yes. So the lecture we selected, they would not have seen yet. So that was one of the help we got from the IT to allow us to access the lecture before it was visible by the students. We know we have a time period where students can see the lectures about 2 weeks in advance. So we selected a lecture that was before and the timing of the events prior to that, so we can ensure that the students aren't previewing or seeing the lectures already. There was another issue with that too, because if we had a repeater that was included, they would have seen the lecture, but that was 4 months ago. So.
Dr. McIntyre has a question.
Thank you so much. I'm really impressed with all of the presentations. Mariana, I'm very intrigued with your study, and I have a question for you. And I know you couldn't disclose too much about your the various extracts you use, of course, for obvious reasons. But I was just curious as to how you and you mentioned a few extract herbs. So it's, I guess, for me, I'm curious as to which ones, you use, which you can disclose, but how you went about determining which would be best for you to use, considering the impact. I mean, this is a very important study with potential impact that would be, could be beneficial to the patients, especially in Barbados, if, there's been a problem, as you mentioned, fertility. So just curious about selection of the extracts.
So I would have done a literature review. There's a lot of studies on herbal extracts that are currently being used. To the extent of where the studies are, the variables used for those studies are a little different. As I would have mentioned, a lot of persons start at the GnRH and they look at the cascade of hormones after that. They don't look above that. So I would have used some of the said herbs from literature. Some of them are very well-known herbs that are found in some of your supplements if you read the back. One of my herbs are from Barbados, a herb that nobody probably thought of. I'm hoping that in the near future I can disclose exactly what those herbs are, but I'll say some of them are just plainly in front of us that we're currently using at this point, but maybe not in the dosage that is required.
Great. Dr. Connolly?
Yeah, thanks. Dr. Atherley, I have a quick question for Asva. Your study on the Indigenous women, I know that you said there's not an awful lot of research in that group, which is why you were kind of interested in studying them. But just in terms of, I know in your abstract you said that there was high maternal and infant mortality within this group. Can you speak to what's causing that? What are the major causes that you see?
So in my literature research, I found that a lot of patients, when they went to the doctor, like there was inconsistent like appointments, like at least, I mean, across the board, there were multiple reasons, but one of the main one was there's like a stigma against the patients coming to the healthcare because they do believe more in holistic medicine versus like actual allopathic medicine. So there were multiple reasons. The main ones was just inconsistent follow-ups of the appointments. Also, like I think a lack of education. Women were not consistent with their appointments, and then they were not following through with what was needed to maintain a healthy pregnancy. That could be a couple of reasons. It's still, again, there's not much research in the field, so that's why I chose to do look at their perspective to see why it was happening. But a lot of the death that I saw was also due to complications in the pregnancy itself. So, stillbirths are actually very common amongst that population. Location, and you could also attribute it to other barriers to healthcare in terms of access. So that there were multiple factors.
Great. Okay, so that's all the questions. I'm being begged for one more. Okay. One.
Thank you for indulging me. I wanted to ask a couple of questions of the students, but one for Mary. You said that this is not standard of care in the U.S., but it seems like it's being used. Has it become standard in any other country or space?
So when it comes to repairing giant retinal tears, there have been many different procedures that have been used, and then based on emergent technology, it changes. Filtered air was actually the standard of care before preferred carbon liquid, but then once it was introduced, it was what is used and trained now in the US. My study has to do with the patient population in Puerto Rico. So it is part of the US, the people have the same training, but it's not necessarily a different country, so I do not know specifically. But I know, just speaking from there, and also the training this physician had in the United States, they knew about the filtered air, but they mostly were introduced using this intraoperative device. So that's how they were trained. But once this physician decided to open up his practice in Puerto Rico, he realized that a lot of the patients they didn't have insurance, or their insurance wouldn't cover the procedure. So they had to absorb the cost themselves if they wanted to help the vision of these people. And considering how urgent of a situation it is, you don't really have time to wait and, look for savings or have the money for this. But at this point in time, I don't know necessarily of other countries. All I can speak of is the United States and Puerto Rico, and also Canada. They also use this.
Great. Okay, so that's it for that session. Thank you all for your engagement and questions, and to our wonderful presenters. I think we had some fantastic presentations today. I'm so proud of all our presenters today. So now we'll have a 15-minute break. You'll be able to get some coffee, bio break, and the posters are up outside now, so you can also take a look at those. We do have a People's Choice for the posters as well, so you can get little slips as well. Our student task force member at the door has the slip, so you can just choose which poster you would want to win that prize. And once we come back, the students will have their chance to network with the faculty as planned. And we'll talk more about that once we come back in, but you're free to go for 15 minutes. Take your seats. I hope you had some really fun discussions with our faculty. Thank you, guys. So our guest speaker is next, and Dr. McIntyre will introduce her for us. So this is the final hour or so of our symposium. After the guest speaker, we'll have the awards and just some ending words. But thank you for your engagement so far. Oh, for now? Oh, yeah, afterward, I'll release you for lunch outside. It's already here, but there's an hour between you and lunch, But yeah. But there is coffee in the back. You can continue to have that.
Hello again, everyone. I'm happy that we're able to still have a number of you in the room with us. We're now at the highlight, just before the highlight of our day's events. Let me introduce Dr. Valerie Crooks, PhD. Dr. Crooks is renowned for her research expertise in health geography and health services. She is incoming Associate Vice President, Research at Simon Fraser University in British Columbia, Canada. Dr. Crooks has dedicated her career to understanding the intersection of health geography and social justice. She has 4 years of inquiry in her research work: disability and chronic illness, primary health care, palliative health and social care, and medical tourism. Her research explores the impact of health policies, systems, and technologies on vulnerable populations, with a particular emphasis on marginalized communities. Dr. Crooks has extensively published in prestigious academic journals and authored numerous book chapters as an accomplished researcher and scholar. She has also received several accolades and research grants for her outstanding contributions in the field. In addition to her research, Dr. Crooks actively mentors and guides the next generation of aspiring scholars. We are honored to have Dr. Valerie Crooks as our guest speaker at this symposium, where she will share her insights on listening to diverse communities across Barbados to address health inequities, a case study of medical tourism and sector development. Dr. Crooks.
Thank you for that introduction. It's always a daunting position to be between you and lunch, and actually awards in between. So this is a topic that I could talk about for a very long time, but I'll make sure to be within the time. So first off, I just wanted to situate myself a little bit in relation to today's presentation. Yes, This is me. And so thank you so much, Dr. McIntyre, for that introduction. And so I did just want to situate my work in relation to some of the areas that you're coming from and some of the presentation topics that we heard about already. So I'm a health services researcher. I've worked closely with clinicians, collaborated with clinicians, collaborated as well with other epidemiologists, social health researchers, et cetera. And so in my presentation today, I'm not going to talk about a single study. What I'm really going to do is present to you what I would consider to be a program of research. So pulling together multiple studies that have been funded by many grants from many different funding agencies to draw together some insights across them. The other thing that I wanted to mention as well is in my faculty role at Simon Fraser University, I hold something called a Canada Research Chair. So I have 80% protected research time in my position. So I'm incredibly research intensive in my role, as well as was mentioned, I'm just about to step into the role as Associate Vice President Research at the university. And so whether it's at the end of this presentation, a question, or even if you want to come and talk to me later, I'm very research interested, very research active, and happy to talk to you about anything that you're thinking about in relation to that. So I want to situate my work on medical tourism a little bit. So when I'm thinking about medical tourism, I'm thinking about it as part of a larger sort of grouping of what I would consider to be global healthcare mobilities. So the movement of patients, the movement of healthcare providers, including those that are training to become healthcare providers who cross national borders in order to do things like access medical education. So there are parallel movements in between, many of your situated experiences and the context of medical tourism. Sometimes also the movement of health information across borders, as well as the movement of financial capital for the purpose of delivering or receiving or training for healthcare. So these mobilities, these movements, these are what have drawn me into considering medical tourism. As a health geographer, I'm fundamentally interested in mobility and movement, and so that's what brought me to this topic. But in particular, in my work, I really focus on mobilities and movements that are untracked, untraced, and unregulated. So there are some movements across national or international borders of the groups that I just mentioned that do have some amount of tracking or some amount of tracing. So for example, in relation to health worker migration, sometimes there's bilateral agreements between countries that set up quantitative guidelines with regard to what the movements will be, even policy initiatives that will guide where people will be going. And then there are other mobilities that are untracked, untraced, unregulated. We don't know how many are going. We don't know where people are going, and we don't necessarily even know what the impacts of their movements are. And so these are the mobilities that I've really focused on in my work. Before I go any further, I just want to clarify what I'm talking about when I'm referring to medical tourism to make sure that we're all on the same page. So here I'm referring to the intentional movement of people across international borders to access privately arranged care that is typically paid for out of pocket. And there's a few important considerations there. So the fact that it's intentional is that I'm not, for example, considering a cruise passenger that breaks their leg while they're in Bridgetown and has to go to QEH, or goes to a private clinic here in Barbados in order to have it set. That's not a medical tourist. They're accessing emergency care while they're away. The other thing as well is that it is privately accessed and arranged for and paid for out of pocket. So it's not a bilateral agreement between countries or a cross-border care arrangement. There are cross-border care arrangements within the Caribbean region. There are also many as well across Europe. And I know that there are many students here, I think, from the United States. You might be surprised to know that there are some cross-border care arrangements even between the US and Canada. So close by cities, for example, Detroit on the US side, Windsor on the Canadian side, there is some movement across those borders and arranged care that is taken care of. So here I'm talking about care that's not arranged. So you're not based on a physician referral, et cetera. So why is it that people participate in medical tourism? And I'll let you know as well that this is a topic that I've been studying for a long time. And those people that are interested in going into practice, you're going to encounter patients that are going to come to you and going to talk to you about their desire to go abroad for medical care. So medical tourism is going to cross your path at some point in your clinical career, even if you're going into a specialist practice, because you're going to encounter somebody who had a procedure abroad that you're either addressing or maybe even correcting. So why is it that people participate in medical tourism? Sometimes there's wait lists in their home countries that they find to be prohibitive in terms of the own timeline for receiving care that they want. Sometimes it's about cost. Sometimes it's about the availability. So as well, in relation to availability, sometimes people are looking to go abroad for a procedure that is illegal, untested, unproven, experimental, not available at home for those reasons. In that case, we actually would really call it circumvention tourism. So they're looking to actually circumvene a restriction in their home jurisdiction in order to access it abroad. As well as issues around quality, around privacy. So for example, Barbados Fertility Clinic or Center, that's right here in Barbados, you may have heard of. You come here on a holiday and then 9 months later you are giving birth and people don't know the in-between story. That's just one example of one of the reasons why people go for privacy. And then as well, as I mentioned, circumvention. So looking to get around a restriction, not always legally as well. So an example that I often hear about is in relation to bariatric surgeries, for example. Some people are underweight in order to be considered to be eligible candidates through the public system or typically in their home jurisdiction. But they're convinced that to lose those last 20 pounds, they need to do it surgically. And so they will use their money to go elsewhere in order to find a place where they can access that care. In relation to orthopedics for sports medicine, if you're very young and you've had your first joint replacement at a very young age, and then at middle age you need to have it redone, then you may have maxed out the number of times you can have it done within your public system. So again, that's another example of circumvention. And so medical tourism, it really involves a number of groups. There's all kinds of allied industries that support the practice of medical tourism. So you've got facilitators that have businesses oftentimes in patients' home countries. They help to refer patients abroad and help to make travel arrangements. You have as well insurance companies, travel agencies, et cetera, et cetera. So there are a whole number of businesses and sectors that are brought into the practice of medical tourism, including, as I'll mention over the next little bit, the public health systems in destination countries as well. So I want to really focus on thinking about how medical tourism intersects with health equity. Health equity is a huge priority in Barbados in relation to health policy and health initiatives. I know health equity is a focus as well of your training, and so this is where my research is situated. So I'm not focused on the clinical outcomes of medical tourism. I'm not focused necessarily on what surgeries that people are going for. What I'm focused in on is how can countries that are hosting medical tourism facilities or trying to attract medical tourists actually become harmed by or benefit from this practice. And when I say countries, I'm really especially thinking about their health systems. And so that's what I'm going to focus on for the rest of this presentation. So there's lots of widely discussed potential negative impacts of medical tourism in relation to health equity. So you can have brain drains in the movement of people from the public sector into the private. You can have further entrenchment of two tiers or introduction of new privatized services. You can really as well shift resources out of the primary and secondary sectors and into the tertiary because it tends to really focus on surgical as well. You can also have sort of the crowding out of local citizens from health facilities. So if you have a higher paying international patient than a domestic patient who will not be paying privately for that care, it may take them longer to get a surgical suite assigned to them for their case, for example. As well as there can be as well a loss of public funds to private entities due to tax incentives. So much private healthcare actually thrives on receiving tax incentives from whatever country or jurisdiction is hosting it. And that same is true for the development of medical tourism throughout the Caribbean, which is a region in which there's a lot of development in this sector. And so it happens actually, although it's privatized healthcare, it happens through public funding, through tax incentives, for example. And then also there is the acknowledgement that medical tourism could actually be good. It could help a country such as Barbados and strengthen its health system. So it could reverse international brain drain, for example. So clinicians may be more interested in staying because they can practice on a wider number of people, or they can have a deeper private practice with international paying patients. It brings in foreign investment, which of course is very important in a country such as Barbados. So in Barbados, medical tourism, although it has a clear intersection with healthcare, is really viewed as a form of tourism diversification. So it is driven by the trade sector and viewed as diversification of its tourist sector specifically, as well as bringing increased access to specialists. So when you think about small countries such as Barbados, others potentially in the Caribbean region, you can think about countries that don't have a denominator population large enough to be a home base for particular kinds of medical specialties. But if you bring in patients internationally and you're able to do that successfully, then you may actually be able to have specialists located locally that you would not otherwise be able to support because of the population size. So these are some of the positive things that we hear about. Why should we care about this in relation to the home countries that patients are based in? There's all kinds of things that are discussed, both drawbacks and advantages. So I've put a few here. So for example, drawback, it can really complicate informed decision-making because medical tourism sometimes, but not always, can actually prey on the most vulnerable people because they're oftentimes, but not always, in search of hope, especially those that are looking for experimental therapies. It can also undermine the regulatory restrictions because if you're traveling for something that's not approved in your home jurisdiction, especially if you return and you have a complication, then that actually really undermines those regulatory protections. And then on the advantages side, you can see that it potentially lessens system bottlenecks and offers patients a greater access to treatment options. So this just gives you some situated positioning and thinking about what medical tourism has to do with health equity. My own research, I've really explored issues of equity, ethics, and safety in relation to medical tourism. What you see here are some of the big questions that drive my work. And so for the rest of my presentation, I'm really going to bring you through a large program of work that has spanned more than a decade, multiple funded studies, many, many publications. Typically, when I give a presentation like this, I don't really get that much into the methods, but because we're here in a research symposium, I'm going to share with you some smaller snapshots of particular studies, including what the actual design was. So what did we actually do? And then what did we find from that? And then I'm going to scale it back up to why does this matter? What did we learn? So I'll take you across different community groups that I've heard from. I just wanted to sort of provide just a very brief point of context for this. So at the point at which I started exploring the potential for medical tourism sector development in Barbados, there was a lot of interest in expanding this sector. And a lot of this interest was situated around, I'm sure all of you have heard of QEH. You may or may not know that there used to be a second hospital in Barbados in the north part of the island that is derelict, the St. Joseph's Hospital site. And over a decade ago, the government put that site up for tender, looking for international investors to come in and to actually recreate it as a facility for international patients. The story of what's happened to that is separate. I could talk for a very long time just specifically about that, but that particular development and Barbados explicitly seeking to get into this sector is what initially drew my attention into Barbados. So the first group that I'm going to talk to you about, I'm sure you didn't think I would even go here, but we did a really very interesting study where we actually did a focus group with lawyers in Barbados because we wanted to actually understand, what do they view their roles are in relation to developing this sector? What roles can they play in the creation of a medical tourism sector in Barbados? So this is the published paper from this particular analysis, but what we did was we ran one focus group with lawyers. We rented a space actually in a building downtown, had catering, like great honoraria, all of that kind of stuff, worked really hard, pounded a lot of pavement to get people to agree, and ultimately we had 9 lawyers agree to participate. So they had a range of practices and a range of kind of areas of law that they specialized in. And so we really wanted to explore what their forward-looking or prospective thoughts were on the professional rules for lawyers in developing a medical tourism sector here in Barbados. So what did we hear, or what did we learn from this focus group that we held with lawyers? So it was really interesting, actually, because we found out that they did view themselves as having distinct roles to play in relation to this sector. They would be involved in doing things like assessing liability protections, determining barriers within immigration law. So, for example, some of the models of medical tourism in Barbados that have been discussed involve physicians from abroad coming to practice here for short periods of time, almost purchasing a membership style of practice to be able to practice in particular facilities. So this brings up immigration aspects. Looking at gaps in relation to physician licensure, looking at desirable or corporate ownership strategies. But the last point here was the one that I thought was very interesting, which was that the lawyers said that they felt that they would need to play an active role in protecting the country's reputation. In that reputational protection is something that's very important, because when medical tourism goes wrong, then it places a spotlight. And when you place a spotlight on a country that's viewing this as a form of tourism diversification, the last thing you want to do is create any reason why tourists don't want to come here. And so lawyers felt like they had a really specific role to play in relation to that aspect, which was interesting to hear them talk about. And this focus group I ran with a colleague of mine who's a professor of law at Harvard. And we came and did this focus group, and it was, again, a very fascinating conversation. So again, I'm just going to walk you through different stakeholder groups or community groups that I've talked to. So also did a focus group, 2 focus groups actually, that were comparative, looking at citizens, so essentially healthcare users, and nurses, so healthcare providers' perspectives on thinking about the development of a medical tourism sector here in Barbados. Once again, we did these as focus groups. So each focus group was about an hour and a half in length, and they were both analyzed thematically. And in both focus groups, we really explored the concerns and expectations that people had around the development of a medical tourism sector in the country. So we talked again to health system users and healthcare providers in this, and this was a really interesting set of focus groups as well. So what we found from these focus groups was that in general, all of the participants really commonly viewed health services export as a niche form of tourism. So again, really similar to what the trade sector representatives in the government here view medical tourism as, really seeing it as tourism diversification. They felt as well that Barbados is already deeply involved and integrated in existing international networks of care. So, for example, participants talked about health workers being trained here and ultimately practicing abroad as being part of these networks of care, as well as networks of care within the region where it's not uncommon for somebody to need to go to a neighboring country or for them to come here for care. And also, especially for those who are financially able to do so, the movement of patients from Barbados, especially to, say, Miami, for specialist care or for surgical care if needed. There were also a lot of concerns about whether or not the development of a medical tourism sector would really integrate and cause benefits or create benefits for the local health system and the economy. But also, I thought is very interesting as well, because both groups really talked quite a lot about the possibility of medical tourism creating health system disruption rather than improvement. And just as an interesting sort of side note, what does that really mean? So, for example, from the health system user group that we talked to, one of the things that they were particularly concerned about was if the medical tourism sector were to become quite robust in Barbados, then they would no longer be actually able to go to Miami, for example, for healthcare, and then also use that as an opportunity maybe to connect with friend and family networks. In other words, that their care networks would go from maybe being regional and international to becoming more localized if they were to obtain care that their insurer had provided or care that was approved through the public system. Another group that I have networked with in this work, that again, as I said, has spanned over a decade. So health workers and healthcare administrators. So just gonna walk you through another study that we've done. So in this case, this was a study where we did in-person interviews. And so they were semi-structured. Semi-structured interviewing means that we went in with particular questions that we wanted to ask, but then we were open to topics and thoughts that participants wanted to share that were related but not covered by the questions. And so in this case, again, we were exploring this forward-looking medical tourism sector development and looking at what people thought the health equity impacts would be specifically on health human resources. And so you can see, again, this list of participants was quite varied, but all of whom they were either administrators in health human resources, they were trained in, they were decision makers in, or they were government bodies or allied businesses who specifically intersected with the HHR or health human resource sector. So what we found from these interviews is that many people viewed the development of medical tourism in Barbados as an opportunity for health human resources and an opportunity for, in particular, the development of new jobs. They anticipated a lot of positive impacts as a result of the development of this sector, so including impacts such as improved quality control, new training opportunities, and health worker retention. And I hear this a lot, not just in my work in Barbados, but throughout the region, where there's a view that if you start to try to attract international patients, then things such as the kind of quality of care that you offer is going to need to improve in order to bring those dollars in. And so that will have spillover effects, including creating improved work environments for health workers. As well as some anticipated negative impacts, so longer wait times, the shift as well in health system planning priorities. So if you are going to plan to develop a medical tourism sector, then you're shifting a priority away from domestic patients, domestic priorities, and what the top needs are of your own citizens, which that in itself can be a very concerning kind of movement that needs careful thought. And then a final stakeholder group that I'll just share based on a study that we did. So I've said here, I mean, it's kind of a broad sweeping statement, but all health system providers, administrators, and users. So in this study, we did 50 key informant interviews, which is a lot of key informant interviews if you've ever done interviewing. And so what we did was we looked for people who represented particular sectors. So we had 15 people who had represented public healthcare in Barbados, 15 who represented private healthcare, 15 who were involved in medical tourism in some capacity, and 5 representing civil society, so NGOs, for example. And we wanted to explore with them the intersection between medical tourism sector development and health equity. And so what we heard from them is that there is a general concern for the potential impacts of medical tourism on health equity, and there's a strong awareness that potential health system benefits may not materialize or that they'll be overwhelmingly felt in the private sector. And I think many people who live locally and have seen international investment come in have probably seen over time how that investment has not directly benefited local citizens. And so this concern still exists in relation to medical tourism. I've given some granular examples of what this looks like, but again, recognizing that it's between me and lunch, I'll just let you read them as the slide is up. So what I just want to do is share with you some takeaway messages. So what do all these analyses, what does this program of research that has spanned a significant amount of time, significant amount of research dollars and capacity, what does it really tell us about how we need to move forward in relation to medical tourism sector development here in Barbados? So first off, we need to think about how public revenues can exceed any public costs. So in other words, that the revenues and what the public is going to get, whether they're dollars or whether they're benefits, are going to exceed whatever those costs are, especially the dollar costs. As well, we need to think about if there are any legislative commitments that are made around medical tourism, and this is a practice that we hear discussed within governments, including right here in Barbados. We need to make sure that those kinds of legislative commitments and other promises actually result in local health systems actually seeing tangible benefits as a result of this practice. We need to think about what kinds of policy mechanisms we can actually put in place to ensure that things such as to ensure that local patients actually can benefit. So there's sort of two strategies that this can happen through. One is to make sure that the pricing of these clinics is something that's affordable to local citizens, and that could even be through two-tier pricing within this private sector. The second is to think about, should medical tourism clinics, facilities, hospitals, et cetera, be required to have a percentage allocation of their time, their resources, and their facilities being directed at local patients. If that doesn't happen, then the spillover benefits for local people are almost negligible. As well as thinking about how, for example, the regulations regarding the employment within this sector need to do things like making sure that privately paying patients are not reaping benefits that are not also enjoyed by those patients that are in the public sector, especially when you think that health workers are a resource, publicly funded resource, typically, that are invested in by their local citizenry through taxation that goes into education, et cetera, et cetera. And then also think about how routine assessments of both the kind of major economic measures as well as routine assessments of the health system can actually incorporate factors that relate to medical tourism and can do things like track various points of concern that we have to make sure that they're not being undermined by the development of a medical tourism sector. And then I'll just, in one final slide, just show you how I've scaled this work up. So this is, again, a more than decades-long case study focused extensively on Barbados, but this is only part of much larger work that has happened throughout the Caribbean region. And throughout the region, what I've learned from my work and my studies across the region, all of which are published. Right now, I'm working on actually translating these 8 key lessons that I've learned about medical tourism, some of which you can hear resonating throughout this presentation. I'm working on right now bringing them into a final book, but as well as mobilizing them as key talking points for particular policy audiences. And this is how we do things like take our individual studies, scale them up, move them on, and mobilize our messages to make sure that there is impact, as well as a number of the specific case studies that I've mentioned. These are studies that have been picked up, for example, in PAHO documents. I looked at one yesterday from the UN that actually cites one of the studies that I mentioned. So again, it's these kinds of little messages that you want to kind of figure out, and then you want to identify ways that you can mobilize them in order to have that broader impact. And with that, I'd just like to thank you for your time. And there's lots of funding behind this. And if anybody here has any particular interest in these topics, I'm happy to share publications with you. But as well, when we're out mingling and when we're at lunch, I'm happy to have larger research conversations. So thank you for your time.
Thanks, Dr. Grits, for that great presentation. Does anyone have any questions? Okay, Dr. Date.
Thank you so much. That was awesome. I think in the last 2 years or so, medical tourism has been really pelted at us, but more so from a medical marijuana perspective. And especially because you kind of had that focus group with litigators, I'm really interested to see what came up as it relates to that.
So the point at which we did that focus group was before that particular form of medical tourism was on the radar. That is definitely a form of medical tourism that I've seen coming up throughout the Caribbean region in particular because of the close proximity to Canada, the US, the established travel routes, et cetera. It's one that I'm interested in looking at more specifically, and also because it tends to have less of a direct connection, especially at least to like tertiary care and use of, for example, hospital space, for example, then it does sort of bring up other kinds of health equity concerns. And then I could tell you that from that legal focus group, even if I recreated it at this moment and had them here, their biggest concern would be around any jurisdictional circumvention. And so Barbados is able to plan for what happens in Barbados, but Barbados can't plan for what happens when somebody returns to their home jurisdiction. And so doing that careful information sharing with patients, which is one of the most challenging things around medical tourism, is ultimately informed consent because you are crossing jurisdictions. So then the final point around that would be not malpractice because of the type of care that people are receiving, but specifically if there were ever any sort of legal implications, then understanding what role and responsibility Barbados or the particular location that somebody went to would be playing in that.
Yeah, great. Because I think right now there's been lots of articles and discussions, especially because you had that slide up talking about how you focus on the ethics and everything and who benefits, who won't. There's a lot of fear, especially for the everyday local Barbadian, that the small man, the small farmer will lose out, and persons who are in higher socioeconomical status can build the farms and sell the marijuana. And then, for example, our Rastafarian communities get left behind. So it's a very complex topic, so it's really great to see that you're so involved.
And so even when you take it out of the medical marijuana and you bring it into even the formal healthcare service provision, it is the exact same. So who is going to benefit, who's going to thrive, who's going to have the dollars? It's going to be international investors that come in to do it, or it may be the local private clinics. And so the local farmers that are missing is the same as QEH as like being on the sidelines, but you know that if there is a significant complication, where is that patient going to end up? They're going to have to go to QEH. And this is where you get at, actually medical tourism is not an entirely privatized practice. There is spillover into the public system. Yeah.
Dr. Leboff?
Thank you so much. My question is, if you can say which medical procedures are most in demand on Barbados, and based on that, which sector is most likely should be financed or developed, and which medical specialties become more competitive based on that?
Great. Okay, that's a great question. So if anybody wasn't able to hear, it was what sectors or what procedures are most popular in Barbados that people are coming from, and where really should that sector, like where should we focus on sector development? And so a slide that I had towards the start of my presentation, I mentioned that I focus on mobilities that really fall into what I call the triple U's: untracked, untraced, unregulated. And this makes numbers people very nervous. It makes it very hard to even have a conversation because there is no tracking. So when I leave Barbados, for example, on my flight tomorrow, I'm not going to report when I'm leaving. I'm not going to report to the customs agent that I have or haven't had any medical care while here. When I enter Canada, they're going to ask me if I've been on a farm because they're concerned about the transmission of zoonotic disease. They're going to ask me if I have over $10,000 of currency because they're concerned about money, fraud, et cetera, et cetera. They're not going to ask me if I've had medical care. So all numbers about medical tourism are wrong. Unless you get to the scale of a specific clinic, a specific facility where they are literally pulling their numbers from a database and they're printing them off and showing you, then they're all based on mathematical models. And actually, believe it or not, there's a lot of politicization of medical tourism as a practice. And so your models are going to be built based on how you want to swing. So if you in Canada, for example, there's a think tank that every year publishes a report on the number of Canadians that have been involved in medical tourism. And you sort of think, well, why would this think tank even care? Well, they have a pro-healthcare privatization mandate within Canada. Their goal is to make it look like many Canadians are going abroad and we should retain them by creating a domestic privatized system. And so that's their tendency. And so this is where it gets very hard. So you have governments that are making decisions around medical tourism sector where you don't have hard and fast numbers. And so actually a lot of times in terms of even the question you asked in terms of what are patients accessing is a little bit like reading tea leaves. Globally, the medical tourism literature and those involved in the industry will want to make you think that people are going for big, bold procedures and they're crossing world regions to do so. Most of it is not that. It's mostly people that are making fairly short movements within their region or potentially in established touristic directions. They're typically going to be accessing something minimally invasive like dental care. minimally invasive cosmetic surgeries. And then second to that would be the people that are on wait lists that are looking, and that's where you can get a better sense of what people will go for. I mean, as far as I'm aware, Barbados is number one kind of medical tourism import-export that it has done well for years and is known on the international level for is a fertility center. And then everything else is just something that kind of pops up and fades down and pops. I was, at the end of last week, I was in a building in Bridgetown that is being renovated, probably not the one you're thinking of, and that's being built right now, the clinic. That's not the one I'm talking about. And I'm talking about something that's an existing business venture where they're looking to add another arm to that venture, and that arm includes a medical tourism center, and they're building a clinic right now. And I'm not talking about the building that's going at the back of the private hospital there. So it becomes very hard to actually even answer a question like yours. And so it makes it very difficult to, bringing it back to this health equity issue, it makes it very difficult to make sure that people are going to actually benefit when you don't even know what the best interests of actually attracting international patients will be. Yeah.
All right, thank you so much.
Yeah.
Great questions. Any more? Yeah.
The diaspora communities that are located out there in the United States, Great Britain, and Canada, and these countries, they represent almost 50% of our local populations, meaning more than half of the persons who are born in an island migrate and live in a different country, usually one of these first world countries. And a business model that has been used in terms of cultural tourism, arts, culture, carnival, these sort of activities, is really to focus attention on these nationals coming home for these grand activities. I wonder if in your research you paid attention to in the Barbados context, coming back to Barbados for medical care, as happens in Latin American countries, and if that model is viable. You talked about the nationalization of healthcare, which is, if complications, you have to go to QEH, but is that a model that can work for medicine?
So these 8 cross-cutting lessons that really have become very clear to me throughout my work across the region. Number 4 is that diasporas are important patient groups in medical tourism, and they're rarely discussed. So when I've done things like I've been part of creating Jamaica's platform for medical tourism and working through a funded initiative to make that happen. And many times I was speaking with people in government offices where they were imagining medical tourists as being, somebody in the United States who already has a passport and they have $20,000 and they have this sort of thing that they need to have addressed through medical care, and they're going to come to Jamaica. But then when we went out and talked to people in the clinics, you actually already realize that a lot of the patients that are coming that are international, if they aren't cruise tourists or slip and falls in a hotel room, then they're diaspora members. And it's really interesting because, as I was mentioning a little bit ago, the medical tourism industry itself wants you to think that it's big people making big, bold movements, traveling all over the world for incredibly complex procedures. But a lot of times it's regional, and then the diasporic networks is another strong one. Whether that would be a viable group of people for care in Barbados, that would have to be explored. But in other countries in the region, for example, including within Central America as well as in the Caribbean, you hear that, especially around dental care. where you can get price point and accessibility that is distinct from what people would be able to access at home. And so if you create the market and market it correctly, then you'll have the diaspora members that will, when they're returning, whether it's for crop over or whether it's for a holiday or to visit friends and family, then they'll be accessing that care. And that's something that, in general, in relation to medical tourism, is not discussed a lot, but is something that is incredibly viable to think about here, because that, in my opinion, is a very large group, as well as members of the diaspora as potentially becoming investors in the sector, as well as working in the sector, because they have their recruitment networks if they're practicing in the US, if they're practicing in Canada. Yeah.
Thank you. Okay. So thanks for those great questions. Thank you, Dr. Kurtz. So I guess now we go to the most important part of the symposium, which is the awards, basically. I invite Dr. McIntyre to come up to give out some of these awards while I get my notes. One sec.
And we're promising we're not going to be too long. Right? But this is the most exciting part. I'm excited to be part of giving these awards out to our great presenters. So, yeah, go ahead. Do you have the,
Okay.
do you have the envelopes?
Oh, 1 second. Okay, so we have prizes in the poster presentation section, in the full research project, our works in progress section, which is session 2, and session 1, so I'll do them in that order. Our participants are basically getting money towards the development in some way, and you can just tell us what you would like. So for example, that could be a subscription to Boards and Beyonds, for example, or Osmosis in the dollar amount that we will say, okay? So today, Dr. McIntyre basically will shake your hand and give it to you. The one prize we have in person, because it's a known thing, is the People's Choice, which is an Amazon voucher, so that one was easy to prepare. So without further ado, then the poster presentations, we have a prize for work done at Ross and a prize done for work done pre-Ross. So for work done at Ross, we have Arkit Kumar, who presented perceived depression, anxiety, and stress in medical students across different semesters. Arkit, go. Oh, yeah, I don't. He did say no. Thank you. Thank you. So you can stand there. For work done pre-RUSM, we have Joanna. I don't want to call her last name wrong. No. Joanna Kanagara. Defining dopamine meditated changes. No? Yeah. And for the People's Choice, we have Arkit Kumar for the poster. Great. So for the research project, or work in progress, for the colleague prize, we have Miss Mariana Shepherd. We'll reach out, yeah. Great. And the top student prize for that one goes to Mary. So Mariana did the effects of herbal treatment on the HPG axis in PCOS-induced female rats, and Mary showed her case series exploring giant tear retinal detachment. Great job. And in the research ideas, which is a very exciting area with students coming up with their thoughts for future. So in third place, we have Melissa Livingston. So Melissa explored how does iron supplementation affect, or how could it affect physical performance of iron deficient female basketball players. And for the second place, we have Cheryl, exploring perspectives related to HIV in antenatal care. She says the walk is long. And first place in this session goes to Hardin and colleagues. And they are exploring or want to explore medical students' willingness to participate in non-healthcare emergency situations. So these are our winners for our symposium today, and congratulations to all of them. Be in touch. Thank you so much. Thanks to all of our presenters, though. I think everyone did a fantastic job. I'm so proud of all of you today. So if I were to ask someone to summarize the symposium in one word, just shout out some words for me. Exciting, what else? Innovative, what else? Encouraging, I'm here, successful. Any other words? Inspiring, informative. Thank you. I definitely agree with all of those. And this is the time that I extend gratitude to a number of people that kind of made that happen. I did try to preempt it, and I have a long list of people at the back of our booklets, and they're all people that have been involved, including all of our presenters. And our faculty supervisors, because there are some faculty members that already are doing a lot of supervision for our students, which is fantastic, and I hope to see more of that soon. The leads for the faculty networking, and our wonderful judges as well, Dr. Connolly, Dr. Day, and Dr. Fernandez, and our planning committee. But I do have to single out a couple people. Miss Elena Hill, who's not here right now, she's our manager within External Affairs. She did a lot of the background logistical work for making this come together. I just come up with the ideas, and she helps me to make it happen. So I definitely have to highlight her, and Miss Sharon White as well, who did quite a bit. Neil, Jenner, it goes without saying, your team are fantastic. Also, thank you for Dr. Crooks for coming down and sharing her insights with us on a very interesting topic in medical tourism there. We have a few online attendees as well, so thank them also for engaging with us. I've had a couple of students as well reaching out with the next symposium, so thank you also to the students showing interest in this happening again, and everyone that came today, all the audience members here today. Also, Dr. McIntyre for facilitating some of my my thoughts in making this happen today as well. So it's time for you to go get some lunch. We do have an evaluation form, which I will send to all the attendees by email, and I really welcome some feedback in helping to bring this forward as well. I look forward to students also helping us to bring it to fruition. Aswa was a fantastic help. She was our semester 3 student on board, and her ideas were just phenomenal. I ended it with her intentionally because it wouldn't have been what it was today without Aswa. Her insights were fantastic, truly. She even rounded up some presenters, so I've heard. She didn't tell me that, but some presenters said, yeah, Aswa wrote me in. So I knew that was happening behind the scenes. So thank you very, very much for your insights, and I look forward to engaging with more students to, developing some more research promoting activities at Ross. So without further ado, I kind of dismiss you today, and I really, really thank you guys for engaging with us today. Thank you. Lunch is outside, so you can just go and have at it. Thank you. Well, brunch, I'm told.